Here.
Diego?
Here.
Bishop?
Here.
Thomason?
Here.
Yep.
Right. This is an official business meeting of the licensing committee, and there will be time for public comments, and we do have a timer if it looks like we have a lot of public comments. Please give the speaker's book to Dr. Einer. And again, speakers stay on topic, but there'll be an opportunity for items not on the agenda. So today we have 14 agendized items, and a reminder of silencing the cell phones. And at this point, I think we will begin with public items not on the agenda. Having the speakers list.
And again, for members of the audience, this is your chance to publicly comment on items not on the agenda. And we don't require a speaker slip, but we do it so that the meeting may be orderly and that we may have the full record when we're transcribing minutes. So this will be anyone's opportunity to comment on any item that is currently not on the agenda.
In that case, speaking of the minutes, let us review the minutes from the May 3rd, 2012 meeting. Are there any additions or corrections to the minutes? Seeing none, may I have a motion to approve the minutes as submitted? Thank you. All in favor of approving the minutes? Any opposed? Minutes are approved. Now, we would like to have an update on licensing staffing, and this will be provided by Mr. Wright.
Okay, first off, I'd like to thank the staff for doing an excellent job in the past fiscal year and also currently in this fiscal year. And they've done an excellent job. We currently have only 3 vacancies in licensing, so that's the best we've had in a very long time. So we have 1 OT and 2 MSTs that are in the process. We've interviewed for those OTs and are in the process of doing our other ones and the work for being possibly interviewed for that. In addition, the managers have completed some interviews for seasonal clerk positions, and these are the positions that we're going to use to replace our student assistants with. In addition, we were able to retain some of our retired annuitants while we were in the process of being able to hire permanent intermittent employees to take their place. That concludes my update on the staff.
Okay, thank you. Mr. Warden, any committee member comments on the staffing? Any public comments on this topic? Well, then, moving on to item 5, Mr. Warden, please update us on the business process re-engineering recommendations.
Okay. Staff has completed the revision of the physician surgeon's application and the development of the new fee schedule. And that application just went online yesterday. So the rest of the website has not been updated yet, but the new application is on the web as of yesterday afternoon. That's quite a bit different from the previous application, and it's designed to be a little easier to read and follow. In addition, we plan on changing the website quite a bit, and we will have plan on doing some pop-ups for questions and specific questions that we give the questions on. That will be coming in the future. So once this application will be able to use people who qualify under the new law that is going to go into effect in January under SB 122. So we will have that included in this application. The application will not have to be revised for that.
Could you refresh our memory on what candidate pool that would be?
It's for the candidates who have attended an unrecognized medical school or a disapproved medical school and that have met certain other requirements to be eligible for applying.
Excellent. So you made the one application to accommodate that other separate.
Yes, at this time.
Excellent.
There basically are, once, like I said, we're going to start working on the website next to accommodate the changes for the new position application. And then we will also be redoing our policy and procedures manual for that and for the new law that went into effect. And that concludes my report on that.
Okay, well, thank you for the update. Any comments from the committee on these changes? Any public comment on these updates and changes? Okay, great. Well, moving right along to the strategic plan. And again, Mr. Warden, please give us a status report.
Okay, there are several components that are not slated for implementation until 2013, 2014. And I'll be providing an update on the components that are currently being worked on within the licensing program. Objective 1.1, which requires the program to examine the current continuing medical education structure, its effectiveness, the current California requirements, and opportunity for improvement, was presented to the board at the last meeting in May. Staff is continuing to work on this component, including preparing an article for the newsletter that will inform physician requirements in the law, as well as provide information on available resources. Objective 1.3, which requires the program to define what is necessary to promote safe re-entry into medical practice after extended absences, as well as conducting a review of current data, including ongoing work with the SSMB to determine what physician re-entry practice after long absences need required prior to resuming clinical practice. As part of the board sunset review, this task was completed and is actually sort of ongoing. That FSMB is still looking at a lot of that issue. The board is moving forward with that. Objective 1.4 requires licensing committee or subcommittee to examine FSMB maintenance of licensure and ADMS certification of maintenance and certification initiatives and studies which should be adopted in California, determine how it can collaborate with FSMB and ADMS certifying boards. At the meeting, a meeting was held between the board staff and FSMB at the beginning of October. During this meeting, FSMB provided an overview of their pilot program, informed the board that they were still in the process of implementation. The dates of the objectives will be dependent upon when FSMB has concluded and published sufficient data from their maintenance licensure pilot program. Objective 1.5 is requires licensing program to conduct a comprehensive review of international medical schools. The licensing program has hired an analyst in addition to the current analyst we have, and is working on going through our existing list and contacting medical schools to make sure that they're still current of these requirements. We just started that, and we'll be continuing with that. We have a very long list. Objective 2.1 requires the program to develop a plan to conduct a complete review of all laws and regulations relating to licensing to identify that are no longer relevant and when need to be added or eliminated. Identify requirements that are not necessary to the safety of practice but may be serving as barriers for qualified applicants, as well as simple updating requirements to be with current educational requirements. As part of the board sunset review, this task was completed and as being part of the sunset review for board members. Objective 2.8 requires licensing program to work and clarify the board's responsibility to regulate outpatient surgery centers and paying resources to be effective. In 2012, staff was able to launch the outpatient surgery settings database on the internet site, which complied with the requirements outlined in the Professions Code, Section 1248. Staff is currently reviewing laws outlining requirements, and as well as the other requirements outpatient accreditation agencies. We are in compliance at this time with the website at this time. So, Objective 2.9 requires licensing program examine board responsibilities that eliminate or move to a more appropriate board or bureau programs. As part of the sunset review task, this was completed and it's part of your sunset report. Objective 5.5 requires licensing applications reviewed within 45 days. The program has been in compliance with this component of the strategic plan for this semester, or this quarter of this fiscal year. We are currently under the 45 days, and as of yesterday, we're reviewing applications at 30 days for both U.S. and IM. Objective 5.6 requires board establish means of better educating staff about the board's activities, including encouraging staff to attend meetings, and we have been doing that in addition. So the staff can generally only attend board meetings when they're in Sacramento due to travel restrictions. We do provide other meeting requirements that we provide updates to the staff on when the meeting has been completed and what new laws or regulation changes are coming down. Objective 5.7 requires the board to establish a means of better educating board membership about operational activities, providing tours, and we've been working on that also. So when you come to our office, we provide you a nice tour of our facility. And that's the end of my presentation for that.
Well, that's a lot of activity for our strategic plan, but you're not done yet. Next, we're going to hear from Mr. Warden on physician supervision requirements for allied healthcare professionals.
Before you begin, perhaps you ask if there's any.
Oh, sorry, you're right.
Or public comment on 6.
We've had such acceptance of everything up to this point. Committee, any comments on the strategic plan update? Any public comments on the strategic plan update? Thank you, Mr. Hopper, for keeping the open meeting open. So now we're ready for the supervision discussion.
The supervision discussion that we're going to have is just what the medical board has, but also some other boards that are medically health related. So some of these supervision requirements the board has no authority to change. So the community or free clinic and nurse practitioner, certified nurse midwife, or physician assistant, or an optometrist supervised in an optometrist's office. Licensed midwife, supervision requirement is yes, and supervision is provided by a physician and surgeon with current practice or training in OD. And the ratio for that physician and midwife is 4:1. Student midwife is not licensed and does not require registration. They have other requirements to be enrolled in the school. Supervision is required and is provided by a licensed midwife or a physician surgeon with a current practice or training on OB. Registered dispensing optician, no supervision required. This is a business license, and so there's no supervision for that. Also,
registered dispensing optician. That's one of our bricks and mortar, actual physical premises registrations, is it not?
Yes, it is. Registered spectacle lens dispenser, there's no supervision required. Registered spectacle lens dispenser training, supervision is required and is provided by the registered spectacle lens dispenser. Registered contact lens dispenser, there's no supervision required. The registered contact lens dispenser training, supervision is required and it's by the registered contact lens dispenser. Research psychoanalyst, no supervision required. Student research psychoanalyst, supervision is required. It's provided by a graduate psychoanalyst, licensed physician, surgeon, psychologist, clinical social worker, licensed marriage and family therapist, or a graduate research psychoanalyst with a minimum of 5 years of postgraduate clinical experience in psychoanalysis. Polysomnographic technologist, supervision is required, provided by licensed physicians and surgeons. Polysomnographic technician, supervision is required and is provided by physicians and surgeons. Polygraphic technologist, supervising polygraphic technologist, registered nurse, physician assistant, respiratory care practitioner. Registered polysomnographic training, supervision is required, and it's by physicians and surgeons as noted for a polysomnographic technologist, supervising technologist, registered nurse, physician assistant, respiratory care practitioner. Physician assistant committee, physician assistant, supervision is required. It's by physician and surgeons, doctor of podiatry medicine, and practicing with any physician medical group. Physician assistant, the supervising physician may choose one or more of the following 4 mechanisms to provide supervision. The physician sees the patient the same day that they are treated by the PA. The physician reviews and signs and dates medical record of every patient treated by the physician assistant within 30 days of treatment. The physician adopts written protocols with specific guide of the actions required by the PA. The physician must select, review, and sign and date at least 5% of those medical records of patients treated by a physician assistant according to those protocols within 30 days. Or in special circumstances, the physician may provide supervision through another mechanism approved in advance by the physician assistant.
You're not going to dance. What?
Now I'm sort of behind, but I caught you back up. Okay, Board of Podiatric Medicine, supervision requirement for licensed doctor of podiatric medicine is none. Registered nurse and advanced practice nurses that are listed below. Supervision requirement is yes. Supervision requirement varies depending on the function being performed. If required, supervision by a physician and surgeon, dentist, doctor of podiatry medicine, or clinical psychologist.
Okay, Greg, can you go back and read the footnote, because that actually is the crux of this whole discussion.
Okay, the footnote on that one is with written standardized protocols or protocols may be required for some functions, particularly when performing overlapping medical functions. Physical presence of supervisor may or not be required depending upon standardized procedure specifications.
Thank you.
Licensed vocational nurse, supervision is required. Supervision can be provided by a physician and surgeon or registered nurse. Psychiatric technician, supervision is required. Can be by the facility director, physician and surgeon, psychiatrist, psychologist, rehabilitation therapist, social worker, registered nurse, or other professional personnel. Speech language pathology, audiology, and hearing aid dispenser board licenses language pathologist, supervision requirement is none. Speech language pathologist assistant, supervision is required by a speech language pathologist or if employed by a public school current credentials authorizing service in language and speech and issued by the Commission on Teaching Credentials. Audiologist is none. Audiologist aid does require it, and it's by an audiologist. Hearing aid dispenser requirement is none. Hearing aid dispenser training is required by, and it's by a hearing aid dispenser. An optometrist requires no supervision. Optometric assistant requires supervision by an optometrist or a physician and surgeon. Basically an ophthalmology specialty. Licensed occupational therapist requires none. Occupational therapist assistant requires supervision by an occupational therapist. Occupational therapy A requires supervision by an occupational therapist assistant. Dentist requires no supervision. Dental assistant requires supervision by a dentist. Dental auxiliary requires supervision by a dentist. Orthodontic assistant requires supervision by a dentist. Dental sedation assistant requires supervision to be provided by a licensed healthcare provider authorized to administer conscious sedation and general anesthesia in a dental office. Dental hygienist requires supervision by a dentist. Registered dental hygienist on alternative practice requires a dentist supervision. And registered dental hygienist in an extended function requires supervision by a dentist. Pharmacist requires no supervision. Intern pharmacist requires supervision by a pharmacist. Pharmacy technician requires supervision by a pharmacist, and the pharmacist technician trainee requires supervision by a pharmacist. Respiratory care practitioner requires supervision by the medical director, physician, and surgeon who is a member of the healthcare facility's active medical staff and is knowledgeable in respiratory care. Physical therapist requires no supervision. Physical therapist assistant requires supervision by a physical therapist. A physical therapist license applicant requires supervision by a physical therapist. Physical therapy aid requires supervision by a physical therapist. And physical therapist students and interns require supervision by a physical therapist. A psychologist requires no supervision. A registered psychologist requires supervision by a psychologist. A psychological assistant requires supervision be provided by a psychologist. A physician is certified in psychiatry by the American Board of Psychiatry and Neurology. Psychology intern requires supervision by a psychologist. Licensed marriage and family therapist, licensed clinical social worker can also be delegated supervisor. Married family therapist requires none. Married family therapist intern trainee requires supervision by a licensed marriage and family therapist, licensed clinical social worker, licensed professional clinical counselor, psychologist, physician, surgeon certified in psychiatry by the American Board of Psychiatry and Neurology. Licensed clinical social worker requires none. Associate clinical social worker requires supervision by a licensed clinical social worker. Licensed marriage and family therapist, licensed professional clinical counselor, psychologist, physician and surgeon certified in psychiatry by the American Board of Psychiatry and Neurology. Professional clinical counselor requires none. Professional clinical counselor. An intern requires supervision by a professional clinical counselor, marriage and family therapist, licensed clinical social worker, and psychologist, physician, surgeon certified in psychiatry by the American Board. Acupuncturist requires none. Acupuncturist trainee requires supervision by an acupuncturist. Chiropractor requires none. Student chiropractor requires supervision by a chiropractor. A naturopathic doctor requires supervision by a physician and surgeon, only if furnishing drugs and ordering drugs. And naturopathic assistant requires supervision by a naturopathic doctor. And that concludes that presentation.
Boy, there are a lot of providers, aren't there? Any questions or comments from the committee?
I have 3 questions. You said the medical assistants can be supervised by physician assistants only if they're in a certain location, like a free clinic or a community health center. Otherwise, physician assistants cannot supervise medical assistants. Is that correct? I'm just curious.
That is correct, unless it's delegated, I believe, by the physician as part of the physician assistant's duties.
Yeah, part of practice. Okay. And then my other question was, so the optometrist can dispense lenses and all that. They don't have to have the optician and lens dispensing license?
No.
Okay, those are separate functions then. Then what?
The
what is
optometrist is allowed to do that,
all of that
based
stuff,
on their
right?
license.
What does an optician? What does an optometrist? That other thing that you mentioned after the optometrist.
There's a-
Optometrist, helper, assistant.
It's an
What does that
assist.
person do?
I'm not exactly sure what they do.
Similar to an optometrist. It's similar to a medical assistant.
I
I
would
guess?
assume it's basically very similar to a medical assistant, but their scope's limited to certain things within the statute.
And my very last question, I'm sorry. The associate social worker who is supervised by a licensed clinical social worker, do you know what the supervision is? How long?
I'm
what
not
the
exactly
scope
sure
is?
what the time frame for that is, but it's part of the process they go through to obtain licensure.
All right.
It's similar to what you would call postgraduate training.
All right. Great. Thanks.
Great.
Thank you for the presentation. One of the reasons that I know that we did ask for this was because as we grapple with the issue of the required supervision for those who do Botox and lasering and things, that the issue came up as to whether or not other nurses or other mid-level professionals do work without the direct supervision of physicians, and I think that's why I asked you to read the footnote, because it really, again, gets down to standardized procedures and protocols as to whether or not a nurse can act independently or not have a required physician on site. So that's something, if we're going to grapple with one area of the practice of a different type of medicine in the beauty field, we also would have to look at the other areas as well, because it's a very common practice that as long as there's standard protocols, that nurses are allowed to work without the direct supervision of the physician.
Well, I couldn't help but think it was interesting that even though we always say we don't license to specialty, but in terms of supervision, there were certain areas where who could supervise had to be board certified. For example, in the behavioral science, it couldn't just be any physician. It appropriately had to be somebody, a psychiatrist, And so it's interesting with the other.
And that's true for the polysomnia.
Yeah, so that was another example. Yeah, so there are times then we do specify, and I don't really know that I want to get into it since Dr. Bishop hasn't raised it, but just out of curiosity, what are the requirements in the dental office with respect to the provision of anesthesia, that went a little bit fast for me. I don't know if we were out of sync on that slide.
I honestly am not sure. I haven't practiced there, and I really don't know.
But do you, what did it that your slide indicate were the requirements
They
for
it has to
anesthesia
be.
provider?
Yeah, they have to be. It would have to be an anesthesiologist who's.
Oh, I don't think so. I think it's
Well,
a-
there's anesthesiologists can practice in a dental office if they're approved, and there's also dentists who are approved for using the same kind of things. So it can't be any dentist. It would have to be one that's trained in that.
But fortunately, that's not in our purview, so I guess we will not worry about that. Any public comments on any of our levels of supervision of the allied professionals?
Simonson, on that note, did I miss about anesthesiologist, technician, and perfusionist? Were they listed on there anywhere? Because those are other professionals that do quite invasive work.
I did not provide anything on those.
Okay.
Perfusionists and anesthesiology techs.
Hmm. Any other comments or suggestions? Are you saying we do need more information?
Well,
on
no,
that?
I would just, if, you don't have to do it at the board meeting, you can just follow up if we can get some more information as to what the responsibility, because those areas are also expanding in terms of their scope.
What was that? The anesthesiologist?
Anesthesiology tech
Okay.
and perfusionists.
I guess I'm not exactly sure I know what an anesthesiology tech is.
I'm not sure we have any in California that I'm aware of. I know they exist, but I've
Yeah, there've been some
never
ads
worked
up.
with one.
There've been some ads out there for them. Yeah,
Huh.
they're mostly actually an East Coast, Southern state phenomena, and in some respects they get involved similar to nurse anesthetists. They're really supposed to be maintaining equipment and doing other things, but because since we don't oversee them, I don't know how their scope is expanding, where they're being used.
Interesting. Well, that would be an interesting question, wouldn't it? Scary one. Any other questions or comments? Well, perhaps Mr. Warden is done for this section, and then I think we're ready for an update on the implementation of SB 122. Ms. Simone, but it looks like Mr. Warren might weigh in on it as well.
Good afternoon. SB 122 price was signed into law by the governor, Chapter 789. Originally, this bill included language that would have only required 5 years of practice in another state or country in order to be eligible for licensure. It would have also only required 1 year of postgraduate training and AVMS certification or 2 years of postgraduate training. This language was taken to this committee and the board at the July board meeting. This committee and the board voted to support alternative language that uses the concepts in existing law but has added consumer protection elements. The language contained in SB 122 that was signed into law is the language supported by the board. This bill allows individuals who have attended and or graduated from an unrecognized or disapproved school to be eligible for licensure in California if they have continuously practiced in another state for 10 years if they went to an unrecognized school, or 20 years if they went to a disapproved school. This bill also requires individuals to be certified by a specialty board of the American Board of Medical Specialties, to have successfully completed the licensing exam required in existing law, to have successfully completed 3 years of postgraduate training, and to not have any discipline on their license in another state or any adverse judgments or settlements relating to the practice of medicine. This bill allows the board to adopt regulations to establish procedures for accepting transcripts, diplomas, and other supporting information and records when the originals are not available due to circumstances outside the applicant's control. This bill also allows the board to adopt regulations authorizing the substitution of additional specialty board certifications for years of practice or licensure when considering the certification for a physician and surgeon. The board supported this language because requiring 10 and 20 years of continuous practice in another state, among other requirements, are substantial enough to ensure consumer protection. The board's implementation plan for this bill is to include a summary in the board's upcoming newsletter, to notify trained board staff of the new law and the new internal processes and procedures, to update the licensing application and directions, The application, as Mr. Warden reported, is now posted on our website, and information regarding the new law and update of application information will be posted to our website shortly. Once application issues are determined, staff will work on identifying the need for regulations. The need for regulations will most likely be brought to the board at the April-May 2013 board meeting, and then we will also send notifications to those applicants that the licensing program is aware of, so they may apply under this new law.
So when the board receives a new application and fees from an applicant, our front-end staff will prepare the application file, assign the file to the analyst who's assigned to work those files based on the first letter of last name. Once the analyst receives the file and determines the applicant has attended or graduated from an unrecognized or disapproved medical school, the application file will be transferred to an analyst who is assigned to analyze this type of application file and prepare the file for ARC. This is in order to for us to find everything being worked by one staff member to identify all the needs that we can come up with for possible regulations, because we have no idea of what's actually out there at this time, and it's going to be a controlled process that the licensing managers for international and myself will be overseeing. Once the file is open and completed and the application is presented, then ARC makes a decision at that point, and the staff will follow that decision. We'll be in the process of training all of our staff in licensing about this new process, and that will be starting very shortly.
So basically what you're saying was the modification or that longer timeline for consumer protection was accepted, and that's what's in the bill that went through. Okay. Any other questions from the committee? Any public questions or comments on that bill and its implementation? Thank you. Well, could it be that we're open for agenda items for our January / February 2013 meeting, which will be in the San Francisco Bay Area? We will have our updates of our normal active items, but I'd like to take any suggestions for any additional items members would like to consider for the agenda.
My only comment, Madam Chair, did you want to hear about perfusionists and
Do we feel we would like to complete the Dr. Bishop, what do you think?
That's fine. Information's always good.
And I would like maybe to request that you consider ACGME and the Royal College of Physicians and Surgeons of Canada have what they now call an international, each of them have an international division where they are starting to look at postgraduate training in other countries. The ACGME has actually recognized postgraduate training in another country at this time, 39 different specialties. The Royal College of Physicians and Surgeons has not gotten to that point yet, but they're already helping set up postgraduate training in other countries, which would lead me to believe that they plan on at some point recognizing them. This would be something that the board may want to consider, because we require, as a requirement for licensure, 1 to 2 years of postgraduate training that's recognized, that's accredited by one of these two agencies. So we need to see if we want to recognize the international part, or if we need to change our regulations, or...
Well, I think it's an intriguing question. How should we phrase that as an agenda item? How can we look at that question? It'll happen. If you'll phrase that in such a way, investigate, illuminate.
yeah, I think we'll call it the International Postgraduate Training.
Okay, perfect. All right, I
like
think that would be interesting to know what's going on with our neighbors. Absolutely. Any other items? Do we ask for public or any items? Well, I think then I would be ready to entertain a motion for adjournment.
So moved.
I hear a second? Do we agree to adjourn?
Just adjourn.
Adjourn. We're
You
done.
don't have to vote on it.
No, make it last longer. Thank you, everybody, and certainly a hearty thank you to Mr. Warden, both for his timelines and his information.
Call the meeting to order. My name is Sharon Levine, and I'm the wet behind the ears president of the medical board. I was elected in July, so I hope you'll all bear with me. This is my first meeting following my mentor and trainer, Ms. Yaroslavsky, and I'm going to call on my fellow board members to pinch me or kick me if I forget to do something. Before we start, I'd like to ask if everyone could put their cell phones on stun so that we're not interrupted during the meeting. On stun. Stun. And board members, iPads are fine on the table and laptops, but Blackberries do cause some interference with the AV system, so we put them in our pockets. This is an official business meeting of the Medical Board of California, and as you can see from the agenda, we have a really jam-packed agenda. I am going to move some items around so that we can focus our energies this afternoon on the critical issue before us, which is sunset review. And so I'm going to move other items either to after we've completed that this afternoon or to tomorrow morning. We do have designated time on the agenda for public comment, and we'll ask for public comment on each agenda item. We have some 21st century technology with us for the first time today. We have a timer. So we're going to ask speakers to limit their comments to 3 minutes. And when you're at the table, there will be a little signal that designates when you're approaching the end of 3 minutes. And when the red light goes on, we ask you to draw your comments to a close. Mr. Einer, Mr. Tim Einer, Mr. Einer, stand up so folks can see you. For anyone who's going to be speaking either to items not on the agenda or to items on the agenda, I'd ask you to fill out a speaker slip. If you haven't, just raise your hand and I'll call on you, and then I'd ask that you fill out the slip afterwards so we have a complete record of who is speaking at the board. Our intention today is to work until 5:30 and reconvene again tomorrow morning at 9 o'clock. Before we take public comment, I have the pleasure and privilege of introducing to the public and to our board members, our two newest board members who were appointed by Governor Brown on August 29th. And we are delighted to have you with us. Two very talented individuals, Mr. David Serrano-Sewell, who is a deputy city attorney of the city of San Francisco, who has just completed serving 7 years, I believe, on the board of the California Institute for Regenerative Medicine, the state agency responsible for awarding $3 billion for stem cell research. This was the very forward-thinking institute created by the public in California when it appeared that stem cell research was drawing to a halt. Welcome, David. We're delighted to have you with us. And Denise Pines, our new member's bookending the board, who was again appointed to the board in August. Denise is from Los Angeles, and she is responsible for strategic planning and business development for her, I believe, her company, Denise Pines Incorporated. She served as president for the Smiley Group, Tavis Smiley Group, prior to her founding her business, and launched Phase 1 Publications in 1993. We are delighted to have you and David both, and with the skills that you bring to us as a medical board. And we're thrilled we now have 4 public members on the board, doubled our numbers. At this time I'm going to ask one additional introduction. Doretha Johnson, who is with us today, Deputy Director of the Legal Division of the Department of Consumer Affairs, who's with us today as a guest, and we're delighted to have you with us. I have speaker slips for items not on the agenda, and just as a reminder, the board does not discuss items that are brought to our attention or take action on any matters that are brought to our attention during this public comment section, other than perhaps to decide whether or not and when to agendize them for further discussion. So my first slip is Charlene Zettel from
Madam President, before we begin, perhaps we could call the roll and establish the quorum and kick things off officially.
Yeah, thank you. Thanks. Mr. Einer, could you call the roll?
Dr. Bishop?
Here.
Dr. Diego?
Here.
Dr. Donahan? Here. Dr. Love? Ms. Hines?
Here.
Dr. Tomlinson?
Here.
Ms. Shipsky?
Here.
Mr. Serrano Schultz? Present. Ms. Jaroslawski?
Present.
Dr. Levine?
Present. Okay, first comment, Charlene Zettel from Donate Life California.
Thank you. Good afternoon. And first of all, I want to congratulate the new members on appointment and welcome them. And to all of you, though, I want to thank you for your service on the board. I know it's extremely time-consuming, but oh so very important for the California public. My name is Charlene Zettel. I'm CEO of Donate Life California. I manage the state's organ and tissue donor registry. We are the state-authorized nonprofit that works in partnership with California DMV, and we put that pink dot on your driver's license. The database is a confidential database, and it's also an online one, but it also serves as first-person consent for someone's legally designated desire to become donors upon their death. The reason I am here today is because despite the fact that we have grown in 6 years to a registry of over 9.5 million people, there are today over 21,004 Californians on the organ and tissue donor registry who wait in hope for a life-saving organ. They wake up each day never knowing if today is their last day. But we all can help. First of all, I want to thank you for putting in your newsletter information about organ and tissue donation and how it saves lives. But second of all, I would like to come today to request that you put on the agenda an opportunity that we all have, and that is to create a specialty license plate. 22 other states in the United States have a specialty plate, and we would like California to be one of them. But to do so, we need to have a state agency, board, or commission be our sponsor. So we would like to be your partners and for you to be our sponsor. We pledge to do all of the reports, collect the money. We already have an approved design in these packets. You have all sorts of, here's our plate design, you see it there, some of the other 22 states. It is very interesting to note that the Veterinary Medical Board is a sponsor of the plate. They want to save animal lives. Well, I want you to join me and save human lives. So I would respectfully ask to be placed on your agenda. I know you have a tremendous amount of demands on your time, but I think that there's no more important thing that we can do than work together to save lives. Thank you. Give me 1 second. Let me see if there's anything else.
30 seconds, I think.
All the information is here in your packet. I think I pretty much said it all. But what the money will go from this plate, it will help us provide a funding source for educational materials. Right now, most people need a kidney, and most of the populations that need kidneys are from underrepresented groups: Latinos, African Americans, Asian Pacific Islanders. So we need to do a lot more to reach out to underserved communities. And one of the things we need to do is to create more educational pieces in language other than English so that people know that they have the opportunity to save lives. Thank you.
Thank you very much. Our next speaker, Mr. Jack French from the California Safe Patient Institute.
firefighting, just point of clarification, you have 3 minutes, and that when that light goes on over there, that means 45 seconds. I apologize, I should have told everybody. So 3 minutes, and the yellow button means, the yellow light means 45 seconds left.
Great.
Thank you. Apologize for not saying that earlier.
Good afternoon. My name is Jack French. I live in Escondido, California. In 2006, I had a hip replacement surgery. I became a victim of a hospital-acquired staph infection, which resulted in multiple surgeries and left me with chronic disabilities. I am here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that has organized patient safety advocates from across the state of California as the California Safe Patient Network. I want to speak with you today about issues related to the medical board's responsibility for physician-owned ambulatory surgery centers. Recently enacted legislation, SB 100, requires the medical board to post information on its website regarding ambulatory surgery centers. We are pleased that the medical board has chosen to include final inspection reports on its website. Also, we recently contacted medical board staff about some concerns we have about the need for access to this web information to be more consumer-friendly. We hope to continue work with staff on this issue. There are two related issues we would like to speak with you about today. First, SB 100 sought, among other things, to make available to consumers ambulatory surgery center accreditation information in an effort to promote patient safety. This is now related information posted on the MBC website as required by the new law. We are concerned that patients who could benefit from this information will have no idea that it's available. We encourage the medical board to undertake a public education campaign to encourage the use of this newly available information. Secondly, SB 100 also required that adverse events that occur at physician-owned ambulatory surgery centers be reported and that fines be levied in the event these reporting requirements are ignored. Adverse events include, among other things, surgeries performed on the wrong body part, retention of a foreign object in the patient after surgery, death or serious disability associated with contaminated drugs, devices, or biologics. We urge the board to notify ambulatory surgery centers and physicians now and periodically of these new reporting requirements and associated fines. As a member of the public, I continue to be uncertain about what will happen under the new law if an adverse event occurs during my care at the physician-owned ambulatory surgery center. To whom will these events be reported? How will the medical board and the California Department of Public Health coordinate the receipt of this information within the legislative timelines, and what are the respective roles of the two agencies? We urge the medical board to ask its staff to report back to them at the next quarterly board meeting on these matters. We look forward to the further implementation of SB 100 by the medical board. Thank you.
Thank you, Mr. French. And Carol Moss, also from Consumer Union Safe Patient Project.
Good afternoon. I'm here today representing not only Consumers Union Patient Safety Project, but the organization that we started, Niles Project, after the death of our son, Niall Moss. Today, I'm going to talk to you about the statute of limitations, but we have a personal experience that I'd like to share to let you understand a little bit more about how important it is that we are clear as to what are the statutes of limitations and how do we follow them. As Jack pointed out earlier, Consumers Union Safe Patient Project is focused on just what it says, patient safety. And we're working very hard to do that across not only California, but in the nation. My husband and I know firsthand about harm. Our son Niall Moss contracted MRSA in the top children's hospital in California, in Orange County, in 2006. We looked at, along the way, how did he get that, first of all, and we found out some answers. And then we looked at how did he die, and how did these things, what happened here? And it was clear that there were mistakes made along the way.
And not to dwell on that, I'll say that we worked really closely with the Consumers Union to establish a new law in the state, 2 new laws, SB 1058, which is called Niles Law, which is now one of the most stringent laws on public awareness and transparency of infection prevention. And we also worked with, that was with Senator Alquist and with Senator Dean Flores, 158, SB 158, to ensure that hospitals have an infection prevention program. The reason I think this is an important issue to us is to this day I've been unable to understand the official process established to report and punish doctors that lack the ability to implement the best practices, and we feel that that was one of the big problems that happened to the death of our son. I think that when the statute of limitations in a case runs out, if consumers are not clear of how to run through the process, I'm sure you've seen on the board many times that there are extreme instances that doctors should be reprimanded, but we've passed the deadlines. So what we're asking today is that there is a concerted effort, and we've talked to the board about this many times and staff within the board, that there is a concerted effort to educate the public through any way possible on how to report these kinds of issues that continue to harm patients today. The state law governing the medical board statute of limitations is a little bit convoluted and unfair. However, as long as the law remains in place, it is very important that the medical board communicate clearly and effectively with patients about the impact and statute of limitations that it may have on their complaint. Briefly, with a few exceptions, the statute limitations provides that a complaint must reach accusation within 7 years of the incident. This means that the medical board's investigation must be concluded, the case transmitted to the Attorney General's office, and the accusation filed by the Attorney General's office before the 7th year time limit expires. The average time it takes within the medical board's process to reach accusation in 2011 and 2012 was 450 days. In addition, once the medical board learns of the incidents from anyone, not necessarily from the patient.
Can I ask you to wrap up your comments?
Oh, certainly. So I will say that we urge the board in effort to better understand the impact of the statute to take a look at how often does the medical board close a complaint because the statute of limitation has run out. Also take a look at how often does the medical board find extreme departure or other failing by a physician and then drop the case because the statute of limitation has run out. We would ask that you focus on this, and we'd be happy to work with you as we have in the past. Thank you for your time.
Thank you. Were there any other comments on items not on the agenda? Thank you very much. Thank you all for your comments. I'm going to now move to agenda item 5, and we will return to the items on the preceding items on the agenda if there's time when we complete this. And I'm going to ask Ms. Kirkmeyer and Ms. Robinson to come to the table. Item number 5 is a review with the board of the issues and summary of our sunset review. For those who are new to the board and for the members of the public who are not familiar with this, sunset review is the periodic opportunity that the legislature takes to look at the authorizing statutes under which the medical board carries out its mission. And on a periodic basis, the legislative basis, the statutory authority for the medical board is looked at to make sure that the legislation and regulations have kept up with what's happening with the practice of medicine and the organization and delivery of care. I'm very grateful to the enormous amount of work that staff has done to organize the sunset review materials in response to the document with questions that were presented to the board, and to the board members who have spent a fair amount of time in committees of 2 looking at different sections of the report and making sure that it reflected the intent and the language that the board is interested in presenting to the legislature in terms of representing what we've accomplished and what we have done and where we see the opportunities going forward. So I'm going to turn this over to you, and what we're going to do, I believe the materials are in the back. We're going to focus this afternoon on section 11 of the report, and this is the new issues and recommendations for discussion today, after which these will be finalized and put into the sunset review. And this is essentially what the board is asking the legislature to support us in doing in terms of revising, enhancing our efforts at both consumer protection and support of the profession. The Section 11, the new issues, is essentially divided into 3 sections: licensing program enhancements, enforcement program and consumer protection enhancements, and then overall program enhancements. And we will discuss the issues under each of those 3 sections. At the end of the section, we will ask for public comment after board members have had a chance to comment on the issues. Thanks very much.
Well, thank you very much. Good afternoon. I just want to also echo Dr. Levine's thank you to the members that reviewed this. I know the first draft that we sent out was lacking in a lot of things, and we got a lot of good feedback from that, so I appreciate you taking that look at it and giving us the positive feedback that we needed to complete this report. So thank you to those members on those committees. Oh, you know, I just need to, sorry. Tim, can you grab me the box down there? Sorry. The report you have in front of you was prepared in response to the questionnaire provided to the board from the Senate Business Professions and Economic Development Committee. In addition to the report, the binders that Mr. Einer is bringing will also be presented to the committee. These volumes actually include the hard copies of all the board's studies and publications. And so you can see here, these are going to be, we have 3 volumes of the studies and publications that will be presented, and so we have those here if any of the members would like to look at those. But those are the ones that will also be included with the report you have in front of you.
There are 2,400 pages of documents that we will be presenting to the legislature with a quiz, I assume.
Yes, the quiz, definitely. I want to make sure they...
What is the tax rate?
That's what I was just going to say, Ms. Yaroslavsky. I was going to say we're going to make sure they read it. But just to provide a little background, every 4 years the board is supposed to go through a review to determine its effectiveness and if there is a need to extend the sunset date of the board. The medical board statutes state that the board will remain in effect until January 1st, 2014. Therefore, legislation must be introduced in 2013 to extend the board's sunset date in order for the board to continue. The board's last sunset review was actually in 2004. The sunset review process starts with the completion of the report, which must be submitted to the Senate committee by November 1st. The Senate Policy Committee will review the document and provide information back to the board based upon the review. A hearing will be held in spring of 2013, at which time the board will present responses to these findings. This is also the board's opportunity to re-examine the laws of the board and make enhancements in order to make the board more effective and increase consumer protection. The board has identified 22 issues that will improve the licensing, enforcement, and overall board functions. We're going to go through each issue to provide some background and then provide the recommendation that will go forward to the legislature. On page 146 and 147 of the report, or for under those that are online, it's under tab or bookmark section 11, you will see a listing of the issues. We will request a motion at the end of each section, as Dr. Levine said. We will take each section as a group, unless the members request an item be pulled out and discussed and voted on separately. We will begin with the licensing program enhancements or changes. So please turn to that tab under section 11, or go to bookmark 11 and proceed to page 148. That's our first one. And Ms. Robinson will discuss this section.
Thank you. Good afternoon. I will now go over the 7 new issues for licensing program enhancements that will ensure the laws are written to accommodate the continuing evolution of medical training and testing in the United States and worldwide. Issue number 1. The United States Medical Licensing Examination is a 3-step examination for medical licensure in the United States and is sponsored by the Federation of State Medical Boards and the National Board of Medical Examiners. The exam has 3 steps. The 3rd step is being changed. This part of the exam focuses on the knowledge and understanding of the biomedical and clinical science essential for the unsupervised general practice of medicine. The new Step 3 will administer 2 separate exams, each 1 day in length. The board would recommend to the legislature revising the laws to allow for the changes that will take place in the USMLE STEP examination process, specifically to address the Step 3 migration into 2 parts with 2 separate examination scores. Are there any questions on this issue? Yes.
A comment, because I just got back from the Step 3 committee, so you may want to touch base with them because they are phasing that in. So they're going to still go to 2 parts, but for a while, defined that, undefined, they may still be reporting it as 1 Step 3 score. Okay. And I pointed out that this could be tricky for implementation because that could interfere with how do we interpret how many attempts. So I'm not sure how we can keep that language flexible. So I think David Johnson with FSMD is totally on board with why this is a challenge and is evolving. So I just throw that out there, and that's kind of hot off the press.
Great, thank you. Any other questions? Okay, issue number 2 is the fast track program with regard to medical education and postgraduate training. There is a nationwide physician shortage. Nearly half of the shortage is in primary care. To help address this shortage and to lessen time and fiscal burden on students, there is a movement toward an accelerated 3-year medical education curriculum. At this time, it is unknown whether the number of weeks of clinical training in each core subject and the number of clinical training hours required for graduation will differ from current law. The board would recommend to the legislature revising laws to allow for the evolving method of teaching medical students in year-round classes with shortened academic year requirements and competency-based training methods, and in allowing for training in various settings, not just hospital-based training. Are there any questions on this issue? Yes.
So I just want the record to say, I think it's a very ill thought out plan, that medical school is not too long right now. And it sounds to me like what the politicians are trying to do is to trade quantity for quality. And I think it's a very bad idea, and so do many people I work with.
Okay, thank you. Yes.
Are there any medical schools in California that have moved toward a 3-year accelerated curriculum? Or that are...
No, I don't think so.
Currently in California, none of the medical schools are looking at the accelerated 3-year program, but they are looking at the training and teaching of physicians outside of the hospital-based setting that doesn't actually match exactly with California law. And that would be those that are not based with a university hospital such as Riverside, and most likely UC Merced once it comes up. In addition, if there are other medical schools that are formed, independent medical schools, those would not be associated with the teaching hospital. And the new wave of medicine and how you teach medicine is through community-based settings.
So I have a question. Are we projecting what is going to be the expectation of the delivery of medical education and therefore trying to make our laws in the next year match those laws? Or are we creating the animal that, is it the cart before the horse or the horse before the cart?
Texas has already started its 3-year education program, and basically their 3-year education program is year-round. So right now it hasn't changed the clinical teaching or the number of weeks that we're aware of, but we know that there's a potential that the numbers may not match exactly, and our numbers are set in law. So we wanted to be able to apply some flexibility in California law so we don't have to turn these individuals away who graduate out of the Texas Tech University Health Sciences Center School of Medicine, because they are already started.
So, but is that going to then give a disadvantage to California-trained students by virtue of the fact that they will graduate after, or it'll take them longer?
No.
Okay.
So just to understand or to clarify, it's just that they're going to school in the summer as well? Is that what it is? Versus the other schools that are not going in the summer? That's basically...
Most of the time in first and sometimes into your second year, you don't do the year-round. You have a summer break.
Right.
And this would be a continuous
That's the
3-year
acceleration.
program.
Dr.
Well,
Salmonson?
One paragraph here would suggest a little difference in that the Texas Tech example quoted would issue a degree, but they would have not necessarily passed USMLE Step 2 CS. And so anybody who would, any postgraduate program that would be accepting them would, it's an unequal product, I suppose, because the conventional timetable would have already had Step 2 CS. So obviously if that becomes more common, that difference needs to be well explained, I think, to anybody.
Is that if that individual gets that postgraduate training and wants to come to California or is accepted into postgraduate training in California, that that individual could be looked at for licensure in California, because right now the weeks don't exactly match and we would have to reject that application. So this idea, this concept is looking for some flexibility in our law.
Well, I mean, the entire concept, I'm not sure it really works. I mean, it will cut down the cost of education, but it will stress these kids out a lot more than what they're already stressed. Medical school is one of the most stressful places you can go. And if you look at the shortage of doctors, it's not about medical schools. The bottleneck is the residency programs. CMS put a hold on, you can't expand, you got to pay your own. So I'm not sure this is a solution. I think what you're trying to do is how that we will not refuse those students into the state. I understand that, but I think the solution is just marginal at best.
We agree with that. We do believe that the solution is elsewhere, but in order to be prepared for these students, we do have to have our law. They do go through these other training type of programs.
I would argue that by doing that, you're essentially giving face validity to the programs. If California, as a trendsetter, said we won't accept this unless they meet our requirements, that would send a message to the rest of the country. And I think that's what the politicians need to hear.
If you look on page 151, the section that lists specific requirements of the medical curriculum, I mean, looking at that, I have to say that while I have a lot of agreement with many of the comments that have been said, stipulating in statute the number of weeks of pediatric training, the number of weeks of OBGYN in a medical school curriculum, I think there is some wisdom in saying, creating the opportunity that as medical school training evolves, being limited in terms of access to licensure in California for someone who graduates from a U.S. medical school with an accredited curriculum can't get a license in California because they haven't had exactly these number of weeks of training in these specialties, and 54 weeks in a hospital that sponsors the institution. I mean, I don't think that serves us well, and I suspect a fair amount of this is honored in the breach at the moment. I don't think we're looking at the number of weeks completed, nor are the training programs when they're looking at these medical school graduates. So while, maintaining neutrality on whether or not it's a good idea to compress, I mean, these shortened programs have existed for a long time. Brown has had a 6-year BA, MD degree for a long time. Many of those programs in the 70s actually died out because they were, as Dr. Gananadev said, they were very stressful and compressed the education. So the question is, do we want flexibility so that we don't put obstacles in the way of physicians who graduate U.S. medical schools, accredited schools who want to come into training programs and find that they can't get licensed in California? That's the issue.
instead of all these weeks requirement, what if you have LCME approved medical school? That's what the U.S. schools are and the Canadian schools are. So LCME is very tough agency when they accredit medical schools compared to anybody else. So that might be a solution rather than trying to accommodate this special Texas Tech program. So that may be one way you can go.
We do have those, I believe, in our regulations, the LCME and the Royal Canadian. So those are already there that we do accept those, but we do have these specific requirements in our law, and the only way that we can get rid of this is to put it forward as a recommendation to the legislature. And just so you know, on all of these recommendations, this all has to go through their process of review and looking at it to determine if that's something that they're willing to carry forward for the board as well. So.
Dr. Solomonson?
If we were to propose that change, would that not make international medical schools say, well, then we think we can do it in 149 weeks also? Would they not be able to make that case? I just think we might then have a whole other list of recs that need to be reevaluated that we might not want to reevaluate.
We are currently not accrediting medical schools. The Medical Board of California is not accrediting medical schools, right? We're deeming LCME through our regulations for U.S. medical schools.
We do recognize the international schools. With
No, I know that. I'm saying in terms of U.S. schools.
Right, no.
So we're essentially already deeming.
Yes, we do deem them if they're LCME or the Royal Canadian.
But do we not look at the weeks of training in the different specialties when we consider whether a international medical school is to be recognized?
Yes.
It's based on
Yes.
weeks of this and weeks of that, and at what institution. I'm just concerned that we have a double standard, that we say in the United States we can do it this quick, but you can't, that could be looked at as an unequal standard.
And we also look at them in equivalency, I believe, to the LCME when we look at those international medical schools. So
once we start
looking at
ratcheting down, then we have to say, well, why should any school have X number of weeks if X minus 2 does the job? That's all I'm saying.
Absolutely. Any other comments from board members on this section?
Okay, issue number 3. For over a decade, the board has been discussing the continuing competence and requalification of its licensees and the reentry process for those who have not been practicing. To date, no viable resolution has been identified. The board would recommend to the legislature that the board continue its study of the Federation of State Medical Boards Maintenance of Licensure program and propose solutions at the next sunset review. Any questions?
Yeah. This is not re-entry, right? This is just you're asking. Yeah.
This is maintenance of licensure. Okay. Issue number 4. Current law allows a physician to renew a license within 5 years of expiration. If not renewed within the 5 years period, the license is canceled. Currently, there is no requirement for a physician to demonstrate clinical competency when out of practice for a significant period of time during and up to those 5 years of non-renewal. Disciplinary guidelines require clinical competency examination after 18 months of no practice for physicians that are on probation. The board would recommend to the legislature revising the laws regarding non-practice re-entry into medical licensure to ensure public protection. Any questions?
Well, that's the re-entry I was also looking at. Rather than just that alone, I know we talked about this. It might be difficult to get into a short-term training program because that might be ideal. Like a 6 months or 3 months or something where you pick, they need to go through this training program. Boards, medical boards do that, ABMS boards. If you fail a couple times, they require you to go back to training program for 1 year. So if we can do that, actually it will benefit the physicians, but more than that, benefit the consumers who eventually when these people are going to go and take care of rather than some kind of an exam. So we got to look into that. I know it's difficult to get a position for that, but if we create it, then the institutions will create those positions. That's what I feel.
Okay.
So, Ms. Yaroslavsky? So, along with your recommendations that the medical board be looking into this, might I recommend that you also survey what programs are going on around the state through the educational institutions and what the availability and the breadth and the depth of those, because there are programs out there that I know we have not looked at.
Yes, absolutely.
Any other comments? And to Dr. Gananda's point, the assessment has value only if you've got something you can do about any gaps that are identified. So I'm not sure the assessment's a bad idea, but in isolation, it in itself doesn't really offer consumer protection.
Issue number 5, mandatory email address for physicians would assist in providing urgent information quickly, as well as cost saving on mailing information and renewal notices to physical addresses. The board would recommend to the legislature requiring licensees provide and keep current an email address for notifications. Any questions?
Yeah, there are some people who don't have email.
Yes.
I don't know how they function, but there are some people who don't have email.
Board member opinions on this? I mean, how do board members feel about making that mandatory? I know we've had discussion about this.
I'm going to tell you that personally I do have an email. I know how to use it, so it's not. But I think that there are situations, if there are people that really don't have it, don't want it, and don't use it, might have staff that do or don't. I think that you've got to have some kind of an option where they can opt out, where they maybe have to sign something, they have to opt out, they have to provide an ongoing valid address that's not a P.O. box. Okay, not for public consumption, that somehow that your office has the ability to be in contact with whomever you need to be in contact on an immediate basis, let's say within 24 to 48 hours. But I think that you have got to have it. Mandatory is not a good word for me.
Chair, I will point out that as an attorney, I'm mandated to provide an email address to the state board. In fact, they've given a deadline for all of us to provide that so that the public can contact, because that's considered to be a reasonable way to contact people. So we're mandated.
I think I have a better solution. What CMS does when you don't do electronic billing, they initially give you a reward for doing it. Later on, they stop that. If you don't, they penalize you. So one thing you can do is, you can consider is, if you don't give email address, your license fee will be higher. So there has to be an option rather than mandate. That's what my feeling is. Mandate is not a good word. They give them an option.
So incentives and strong encouragement. Incentives and strong encouragement.
Madam President, I have a legal comment. Whenever you get a chance, I have a legal issue.
Yes, Mr. Hepp.
Just one of the things that the board may consider as it moves forward on this issue, would that be that much like we have the address of record and the confidential P.O. box, perhaps the board will wish to consider the confidentiality of that email address supplied. So it'd be my recommendation, purely from a legal perspective, that the board consider sort of in a definitive statement that any email address so supplied would be in fact not public information and not disclosable to a Public Record Act request.
So you would want that, put that in the language, basically?
That would be my legal recommendation. The policy recommendation, I think, is readily apparent to the board. So,
just so everybody knows, we currently do not release the email address. If you look on the back of your renewal, for those of you that are physicians, when you're filling it out, it does say that won't be released, and we haven't released it. And we've done blasts out to individuals about different topics that people have brought to us, but those all have to be cleared through the executive director, Ms. Whitney, and then we also are very careful with that, and we're the ones that send the blast. We don't allow it to go out from other entities and provide it.
So I think in the language can I ask you, do you know what percentage of licensees have actually provided you with an email address?
Oh,
want to say we have probably close to 90%. We're very, I think we just sent, out of all of our licensees, the last newsletter, we sent it out to 116,000 licensees out of our 132 around there.
My only comment, members, I'm sorry to hog the conversation, my only comment is it sort of switches gears. This is kind of like ice skating in the Olympics. One of them, you know, you have the compulsory, and then you have the technical interpretation. It seems to me that if you make this, in fact, compulsory, then maybe you want that added protection.
Okay, great. Thank you very much. Any other comments? Okay.
Issue number 6, postgraduate training, posting on the board's website. Statutes require the board to post physicians' approved postgraduate training on its website. Current postgraduate training, that is newly licensed physicians, have not completed postgraduate training at the time the information is gathered when they apply. And sometimes there's multiple programs, up to 4 programs. There's multiple years. Sometimes they switch specialties. Information cannot be easily obtained after that point and may require verification, which could be a costly task. Currently, the board posts number of years completed for physicians that self-report on our survey. The board would recommend to the legislature eliminating the requirement for the board to post on its website postgraduate training information. Any questions?
Any comments?
You still will have board certification and qualification, is that right?
Correct. Yes. Yes, this is the postgraduate training in their specialty, and normally it's not completed when they generally apply. You know, they're in their first or second year, and usually a program is 3, 4, and more years.
So what happens to the person that doesn't complete the training when it's had it posted on the website? Will they have to notify you that they didn't complete the training and why, and then have it removed, or what are you going to do?
It's not posted right now, and we wouldn't be able to post it if they hadn't completed it.
Okay, I apologize, I didn't understand that.
This requirement is that we remove that from the law. Right now, the law tells us that we're supposed to list it. We don't, and that's why we'd like to eliminate it, because we don't really see any consumer benefit.
Okay, I apologize, thank you.
Okay, our last issue.
Just to be sure I understand, the law has created a catch-22 where it requires the posting of information that you can't actually post because you only ask for it at the time of licensure, at which point it's not complete, so you can't post it.
It's not complete.
So this is to eliminate the catch-22. Thanks.
Okay. Last issue, number 7, clarify exemption from the corporate bar for postgraduate training in hospitals. We need to clarify statutes to conform to practice. Some training hospitals work with postgraduates in various ways, as employees and as contractors as part of their training. The board would recommend to the legislature revising laws to clarify that unlicensed residents in accredited resident fellowship programs in California are exempt from corporate practice laws.
I thought they were already. Hospitals employ all these residents.
Yes, they
Whether
are.
licensed or unlicensed, it doesn't matter because they're in the training program.
They are, but we need, we've had questions from different groups asking about this, so we need to make it clear in our postgraduate section of our law that they are exempt from that corporate bar.
So it's not currently clear?
It's not clear enough that,
And that's why
they're concerned, so we want to make sure that's clear for them.
So the training programs and the trainees are concerned that they may be in violation of the
Right.
bar and the corporate
I
practice
don't
of
want to
medicine.
violate the law.
But you said you put it there only unlicensed. There are licensed residents too, because remember after their second or third year, if you come to neurosurgery training program, which is 7 years, so they by second or third year they're licensed and still employed by a hospital for the next 5 years. So it shouldn't matter as long as they're in an accredited training program, they should be exempt from a corporate practice bar.
So should it change, or what does it say? Does it say?
What we want to do is clarify it.
Well-
Right now, we need to make sure that they understand that it is not a violation of the corporate practice.
Okay, so what you hear are people sitting on this side of the table
that are not clear on what it is you're trying to achieve. So I have to assume that if I'm not understanding it, that the legislator reading this is going to maybe have similar kinds of questions, so that I would hope that when this is written, it is written in such a way that maybe what you're trying to fix is noted in such a way so there's no room for questions.
If I may, we actually did put unlicensed residents in this recommendation, so it's my understanding that that should be stricken and it should just say residents.
Exactly, residents, right. That's the confusion. That's correct.
Thank you.
Okay, so we have completed the issues.
We have completed the 7 issues. I'd like to, with 2 revisions.
Yeah, and I think it would be helpful if you briefly go through what you've heard, so before we have a motion, so we're clear on what you need a motion for.
Okay. The revisions are Kurt's motion regarding the confidential email address, to add that in, and to take out unlicensed in our recommendation that we just discussed.
Okay.
Third one, is there something about mandate email? Can we make it more incentivized to give the email address rather than just mandate it? That's what.
The language that's in there is if they have one. If they have that mandate provision of the email license, or the email address, if they have an email address.
On page 157, if they possess one. So there would be some kind of opt-out.
So what about leaving out the word mandatory?
To require. We're already at 90% with a purely voluntary system. So.
Okay. Now I would like to entertain a motion to accept these 7 issues to improve the licensing program, and also as revised today to move forward to the legislature as issues for the medical board.
So moved.
Second.
All in favor? Public comment, sorry. Public comment on the 7 items related to the first section.
As revised.
As revised. Teresa Anderson, California Academy of Physician Assistants.
Do you have something on these?
No, I'm sorry, I'll wait my comment.
Julie D'Angelo Fellman.
Mine are on a different section.
Okay. And Yvonne Chung.
Yvonne Chung with the California Medical Association. On the issue of public disclosure of postgraduate training, just wanted to offer one comment. By not posting postgraduate training actually is verified by the medical board. Board certification and specialty is self-reported by the physician. So I just wanted to be clear that you are removing the one thing that you actually do verify and check. It's our position that there are a lot of things that contribute to the quality of a physician. Board certification is one of them. Postgraduate training is another, and that's something that when patients call us asking for how you evaluate a physician, we say, look at board certification, but also look at their training and other factors, experience. So while we don't oppose it, it's just something to think about that while it may not be the most up to date, it is a key piece of information for many patients. Thank you.
The proposal is not to remove the number of years. That would still be something on the survey, but it would be to remove the requirement of what they actually took or where.
I've got a comment on that. I have to say that almost makes me feel less happy with the change. I think if you're going to put a number down, then it should be in what? Or don't even put the number of years.
The number is a self-certification from the physician. And we won't have, they could say that we have 7 years in postgraduate. The only thing that we may have is their first 2 years. So that's the only information we would be able to provide to that individual if they looked on our website. We could actually say that they had taken it at a specific place, but they hadn't actually done 7 years there. They had done maybe the first 2 years there, they'd gone to another place and maybe done another 2 years. So we don't have that subsequent information to verify with those years that they're self-certifying.
So we're going to just put down 2 years because that's the number we have?
If you look at our physician survey, it identifies that this information is self-certified by the physician and that the board doesn't verify it. So we will put in what the physician actually identified. So if they say they had 7 years, we put that 7 years in there.
So I'm confused then what the change is. We are still putting...
The change is, as Ms. Whitney said, we will not put the name of the facility where they took their postgraduate training. If an individual were to contact the board, we would provide them with the information that they provided up to the point that they applied for a license with the medical board, but we wouldn't have any subsequent information past that.
So verification, per Ms. Chung's point, verification of credentials is done at the time of initial licensure.
Absolutely.
There is no subsequent verification of anything else. Other information the board gets is self-reported information. So once someone is licensed and they maintain that license, there's no subsequent credential verification.
I do believe that the AMA continues to gather information from physicians as to where they've gone, but the medical board does not. That's one outlet for an individual to go to.
Any other questions from board members? Any other comments from the public that were not submitted?
So I'm sorry, just a point of clarification, Ms. Kirkmeyer, on this issue, this is on page 158 of 400 here. The board recommends that the law should be amended to eliminate the requirements for the board to post a physician approved postgraduate training. Are you suggesting that the amendment would just be the location of that training, or I just want to be clear, all the years, or?
Well, yes, we can identify that. If you look specifically at the section where this is from, it's from 803.1.
Right.
It's
We're
very
looking at it right
specific as to what is being required there.
Right, approved, and it says, sub 4, approved postgraduate training. And I guess the issue before us is we have a good snapshot of time of verified data, verified information, because that comes to us in the form of the licensing application and other forms supplied by the institution that offered the training. So once we issue the license, essentially that data window, as I understand it, is closed because we no longer verify it or whatever. It comes to us then again, sort of on the self-reporting through the survey. But
and all they report on the survey is the number of years.
Correct.
The location.
And that is self-reported. It's not verified or validated. Correct?
Yes.
Okay.
So if the consumer were to want to know if their doctor was board certified, and the doctor had been licensed by the Medical Board of California, and for argument's sake became later, 5 years, 10 years out, board certified, we would not add that to their...
Board certification is on there.
Yes.
And that will remain on there.
Right.
Regardless of the time in between.
Regardless of this whole issue, it will be on there because they post that on their survey and we post that on our website.
And students that are doctors that do fellowships, and then, there's the medical school education, there's the degree, there's the opportunity of doing postdocs, there's fellowships, there's all these other things. That will not be on the website?
Not a fellowship, no. Their practice area, their secondary practice area, that will all remain on there from the physician survey. I think what else?
Is there anywhere or anyone that would need that information that would be coming to the medical board website to look for it, not find it, and have adverse outcomes?
What I can tell you from the calls that I hear come to the medical board in our executive office, the biggest question is, are they board certified? Of course, are they licensed? I guess I should take that back. The biggest question is, are they licensed first? And then the second question is, are they board certified? And we provide that information to them. And then we also have a link that takes them over to our ABMS, to an ABMS website where they can verify that information with ABMS.
Okay, so there's someone.
Absolutely. absolutely. And then we also provide the information on the 5 boards that we do specialty.
Okay, so can I have a motion? Oh, and I have a second. All in favor?
Aye.
Any opposed? Any abstentions? Okay, please move on to the second section.
All right. And actually, I'm going to split up the enforcement actually into 2 separate sections. I'm going to take the next 3 issues would actually provide enhanced consumer protection related to prescription drug use. So if you would please turn to pages 162 to 164 for these issues. The board has reason to believe that numerous deaths have occurred in the state that are related to prescription drug overdoses. In the last fiscal year, the board only received 4 coroner reports, and only 1 of them was due to a drug-related death. Business and Professions Code Section 802.5 requires a coroner to make a report to the board when he or she believes information based on the findings of a pathologist indicating that a death may be the result of a physician's gross negligence or incompetence. The decrease in coroner's reports could be due to the fact that coroners have to make this determination. In order to alleviate coroners from making this determination, the board would recommend all deaths related to the prescription drug overdoses should be reported to the board for further investigation. This would allow the board to determine if the prescribing physicians were treating in an appropriate or negligent manner. This would increase consumer protection and ensure the board is notified of physicians who pose a danger to the public so action can be taken prior to another individual suffering the same outcome. The board would recommend that a section be added to Business and Professions Code, Section 802.5, to require coroners to report all deaths related to prescription drug overdoses to the board. Are there any questions?
Yeah, is that really what we want? I mean, I'm not sure how much work it's going to create, and what percentage of prescription drug overdoses are related to physicians' bad prescribing practices. I'm trying to look at some science here to see what exactly, because something has to connect. The connection is that if many of these overdoses are related to bad prescribing, yes, there is a serious problem. If there is no connection, then we're creating something which I'm not sure. That's why I'm just curious. Do you have any data on that?
We don't have data, but I don't believe we have the information to get that data from. If we receive this information from all of the prescribers, then we would be able to look and make that determination as to how many at that point.
If I may, the LA Times met with Ms. Mose and myself discussing a report that they were working on, a research study they've been doing over the past couple years on looking at the last 5 years of data for 4 counties in the LA area and the prescription drug deaths. They said there were about 3,000, and half of those were related to the drugs being prescribed to the individual who died. And so based upon that data alone, it's telling us we're not getting very much information about deaths that might be attributed to a physician truly overprescribing versus a patient that is getting legitimate medications but then begins to abuse them unbeknownst to the physician. But those would be the ones that we could then look into. So we would have to look at the numbers. We understand the studies coming out in the next couple months, but based upon that, we feel that that's going on. We know we're not getting coroner reports. We know the prescription drug deaths have risen to a level that there are more deaths from prescription drugs than there are from vehicular accidents, and we feel that this is a time that we should step up and look at what's going on to see if we can address that issue.
And if I can make a comment, I think one of the challenges is that the text here makes a very strong hypothesis without any evidence. I have no problem with, I think what I'm hearing you say is we need to collect the information. the language in the text suggests that we're pretty sure this is bad doctors prescribing too many drugs. We don't have enough information to prove it. I think more neutral language that says, we know there's an epidemic of deaths from prescription drugs, and we need coroner information in order to understand, look at patterns and see whether or not, and whether this is community based or what the causes are. The language is somewhat, it appears to have come to some conclusions in advance of analyzing the data.
Okay.
That was my, I'm sorry, that was my issue. That is, whatever we do has to have science behind it. And we know there are increased number of deaths from prescription drugs. That's a fact. But how is that happening? Is it bad prescribing, or is it depression causing people to take overdose, or whatever is the reason? So if we gather in data to really see what's happening, and if it is bad prescribing, I think we should be all over it. There's no doubt in my mind. But we need to gather the data and look at it rather than come to a predetermined conclusion somewhere there because LA Times thinks so. LA Times thinks a lot of things. That's not what medical building is. So that's what my point is.
Absolutely. And if we had those reports, then we'd be able to identify that.
Ms. Shipsky?
I have the same concern, and actually I brought that up when we were talking about medical errors. They're not always physician errors, and medical errors imply that it's physicians, so we need to be careful about our language. And I would think that this does similar. But my concern is how do we clarify that, because the Business and Professions Code section that requires reporting to the board has an inference that there is some connection with the findings and a physician. So how do we're not indicating, I mean, I understand about the language, but if you do this, you are by inference indicating that the coroner has made some connection between the death and the prescription drugs and a physician. Otherwise, we wouldn't be getting the report.
Well, unless that the language in the code doesn't link back to negligence.
Well, but see, you can ask counsel on this, but I think it does.
But can it not be written in such a way that it says and all deaths relate coroner's report?
Probably it would need a different section.
A separate section.
It would need a different section. Otherwise, the inference by reading the totality is that this is again one more red flag to us about physician negligence. So.
And again, what we're doing is asking the legislature to add an additional section that would require this. So these would all be things that would be put into a bill in the next year.
Well, and perhaps maybe some clarification of the language, and we're not going to wordsmith here, but so that it is not made an inference.
Yes.
That if in fact the coroner has made these findings, that the physician in any way is involved, because we know people overuse their prescription medicines, no matter how they're prescribed. So if we can make that kind of clarification, then I think it would be very clear. And I think it would also, because this will be used, if you got a coroner's report and you got prescription, overdose, it's going to be used obviously to pursue perhaps against that physician, not from our board side, but it could be used, on a personal injury case.
Ms. Yaroslav?
So we've got a couple issues here on the table. One is that our coroner is not reporting deaths of patients that are dying by overdose of drugs. That's first of all. And the question is, those patients that are under doctor's care don't go to the coroners for exam if there's not any reason for them to have not died. So that's the coroner's around to do an autopsy when there's been no medical treatment for the patient, ongoing medical treatment of the patient. So the issue then becomes, I'm not saying that this isn't the way it should be, but I'm suggesting that to put the blame on the coroner's office without having a component of public education of the coroner's office is a mistake. It's unfair to the coroner's office, and it's unfair to the public. So I know that in the past years, before the current enforcement people were in place, that our previous enforcement personnel did meet with different coroners, to the extent that the Los Angeles County coroner had not an idea that they were supposed to report. That's true, they didn't. But once they found out they were supposed to report, they did. But there's lots of people that are supposed to report that don't. So I think that we as a medical board need to, in addition to taking this part and putting this forward, we have to put in place the opportunity for those mandatory people that need to report to be informed, for it to be an ongoing expectation, for regular meetings to be set up, and for regular engagement to happen, because it's an unfair expectation otherwise. And to assume that coroners are not reporting, well, let's assume that they know that they're supposed to report. So
we agree. And just a final comment, the numbers that Linda cited in terms of 2 years of deaths due to overdose in Los Angeles County, wasn't that 3,000?
5 years.
Something like that. A lot. Over 5 years, sorry. You're looking at a lot of reports. You're looking at potentially a lot of reports that will require investigation and some judgment.
But I'm suggesting part of the problem is that people that might not know that they need to report are not reporting, and as well as people that don't need are not going to be reporting because they're never going to see the patient, because the patient has died and has been under the care of a doctor. The coroner's office is out of the picture. So I think we're trying to balance what's not balanceable, and we need to do a proactive education opportunity to those. There needs to be a third part of this balancing act, is all I'm saying.
Not to speak for our executive director, but I think that in the next couple months, this will be one of her main goals, is to reach out to mandatory reporting entities and make sure that they're aware of what they're required to do.
Okay, great.
Okay, then moving on to the CURES program. The Controlled Substance Utilization Review and Evaluation System, or CURES, is California's prescription drug monitoring program. This system enables prescribers and dispensers to obtain a patient history or activity report to assist in identifying patients who may be doctor shopping. There are two problems with the current system. First of all, there is not enough funding to make the necessary upgrades and improvements to the computer system to make it user-friendly and useful. In addition, not all prescribers use the system. In order to improve consumer protection, the board would recommend that all licensees who prescribe or dispense pay an additional minimal fee to support the necessary enhancements to the computer system and staffing to run that system. The board would also recommend that once the system is, well, the enhanced system actually is operational, all prescribers would be required to perform a CURES lookup prior to all Schedule 2 and 3 prescriptions. Are there any questions or comments on that section?
You're going to ask for increased fee from doctors that do prescribing. Is this being done in coordination all with any other of the practitioners statewide that also prescribe?
Yes, if you look, it would also recommend that legislation be considered for all prescribers and dispensers. And if you look, there's a list on page 164. So it'd be physicians, dentists, pharmacists, veterinarians. It's the next to the last paragraph there.
See that?
And I'm sorry, and what's the fee?
We would have to look at what amount of money was needed over the number of licensees that would be coming from.
I mean, because the only reason
the legislature would look at that.
And I mean, because the only reason that you would want to use it is for the protection of the public, but now you're saying that it's going to cost me to deliver the care.
We can put it on your budget.
For a system that might not even work.
We currently have that. We currently have the system that is on its last legs. There was a bill in the legislature this year in an attempt to provide some funding for cures, and it did not pass. This is a really important public health issue, and one that physicians in general and other prescribers are eager to have up and operating.
Have we considered requesting from the drug companies that need prescriptions written to take their medications that they might want to participate in making their use of their medication safe?
Yeah. And it's the crafting of the piece of legislation. The question is the board comfortable recommending that the legislature produce a bill that actually will establish a secure and stable funding source for a 21st century rapid
Drug
response.
companies.
Well, Dr. Levine, the County of Alameda did a similar approach, which I think we talked about last word, and we need to look at too as well. They actually are fining the pharmaceutical companies for the costs related to the return and disposal of prescribed medications, and I think this seems to be in the realm, this seems to be a legitimate request and suggestion to the legislature that since we do have this serious problem and the state does need the funding to be able to track, monitor, and also report on this type of use, that this would be a reasonable thing to make some kind of assessment on prescription medicine.
There are two issues here. One is the user fee. I can see that there. It's like my tax bill. This school district this water district this, even though Prop 13 limits something there. But the second issue is bigger one. Unless you have a you have significantly progressed in your electronic health or medical records, it's not that easy for a physician to look up Q's database in a solo practice that often. Let me qualify my comment that Q's database is probably one of the best we have, and it needs to go much further because it is one of the best things for public protection. We know that, but we've got to get there. So I think, like Mr. Yaslowski said, you've got to look at some other way and also work with the physician organizations, the dental organizations, the osteopathic docs up there, and nurse practitioners. See how can we get them there, where we want to get them, and then put something together, because the importance of this is significant, because without knowing, you can prescribe something else that patient was on. Without knowing that somebody else gave this dose, you can do the same thing. So this is a serious issue. So we talked about the overdose. So the doctor shopping. So all these issues come through Q's database, but we need a lot more work than just us trying to do something by raising doctor's fee by $5 to $10 and come on with some mandated requirements. So.
Well, can we correct that, though? The CURE system isn't an electronic prescribing. The CURE system allows the Department of Justice and the Department of Pharmacy that when a prescription is brought in, they can start running, they can monitor, and they can track the prescribing practices of it. So this does not require the physician to have any electronic records or any costs related to that. This is simply the state monitoring system.
I would just like to recommend that as part of this discussion, maybe put in here that there needs to be some shared responsibility. I'm serious now. So shared responsibility between those that are writing prescriptions, shared responsibility between those that are giving that are the drug companies, and those that are selling so maybe it's the pharmaceutical companies. It could be the drugstore companies. It could be let's take a look at it. We're not going to say you're going to spend $5. We're not going to say you're going to spend 25 cents. But let's say that we know that there needs to be money, and we support this. Like you've got here, we recommend that legislation be considered. We don't know where the fee is going to come from. Maybe there needs to be additional money because on all of our bills for public services in the cities that we live in, everybody tacks on something in the city to something that has nothing to do with anything. So I'm not suggesting you tax apples here, but I am suggesting that there has to be some shared responsibility. And I agree with Dr. Conadev. You cannot, and Dr. Diego, you can't always be asking doctors, as a result of their licensing fee, to cough up some more money. But I think that maybe we can. Some shared responsibility would be a good idea.
And that's why we do have all of the other individuals listed. Anybody that would be
missing OxyContin and Pharma,
right, and so you're looking at, and we could add a sentence in there and looking at other funding sources as well.
Dr. Bishop?
I know this is political suicide, but I'm not for elections. This is fine. I think that the public needs to help fund this as well. I think that they should pay perhaps 5 cents a prescription. Yeah. There's hundreds of thousands of prescriptions. It would be a very painless way to.
Pharmacies.
Well, not but I'm talking about the public itself. Every prescription fee would cost an extra nickel, perhaps. It's not going to hurt the consumer significantly. It's going to give a lot of protection. So.
It already costs a doctor a special fee because the prescriptions are.
And I also disagree that it wouldn't require a physician to have all this electronic stuff, because this specifically says they have to check with Cures before they can prescribe a medication. That requires a computer connection. That requires that the system be up and running seamlessly. When you come to my emergency room and I want to prescribe you some drugs and I can't get the system up, now what do? It's illegal for me to provide those drugs. So I think it does require a smoothly functioning system.
Yeah, that's why we said an enhanced system first
Right.
before we ever get to that point.
But I would take out that we are going to mandate doctors to look at the system and all that. We need to provide a way to get there. I think I'm pretty a big fan of electronic systems where you can really look through and see, eventually prevent complications and drug reactions and overdose and all that. But it takes a lot of work from a lot of agencies, not just us.
Should we consider taking out that sentence, in parentheses, added to licensees renewal? Should we just put require an additional fee for individuals somehow, so that when the study is going forward, that maybe some bright minds will come together and figure out how to fund this?
Look at enhanced funding, but not.
Right, but not identify the source yet.
Exactly.
Because I'm not so sure that this should be, I don't think it should be single sourced.
And
You're not recommending that, I know. But.
Right, but what we can also put in there is including looking at other funding sources for the Cures programmers.
Right, and also if we can clarify that when it was made, the presentation was made to us, this is the enhancement about the physicians being able to look it up. The biggest issue was the state being able to fund actually just putting the system together. What maybe perhaps we can focus on is perhaps instead of making it the requirement of the physician to look it up, because you can't always access systems, perhaps when the requirement should be when the prescription is filled. That in fact, if the filling pharmacist runs it and finds it, because they are probably in a better situation, that they have a requirement then to alert the physician, and a decision can be made from there instead of putting the onus on. Because as you know, when patients come through emergency rooms or they come to clinics or whatever, it may not be possible at that point, but the pharmacist should be able to track it, monitor it, and alert. And that may help significantly, I think, with the cost of the system.
I totally agree with that the medication should not be dispensed until it's checked.
Right, and the
I was
onus
looking
should
for
be
that
on.
where it said that, but because that's my biggest concern is all sorts of things can happen. The writing the prescription is the easiest thing, but when the pills are actually handed to the patient, that's when something should have been, by that point, something should have been checked.
Well, and quite honestly,
I would rather pay.
Yeah, the state
I would
is-
rather pay than have to
Absolutely.
be responsible for checking.
And
Like,
absolutely,
that's the bigger
the pharmacists have had an expansion of their scope of practice over the past couple of years, and I think this should follow their obligation because of the responsibility for counseling. Once they find this person on there as a drug seeker, I think they should have the responsibility not to dispense the medication and to alert the prescribing physician.
So I think that what we're looking for is to have a seat at the table in the discussion, that you're trying to put this into sunset. You're not expecting that the medical board is going to take the flag and march down the hall. So the legislature, you're looking to be, we're looking to be at the table to make sure this works out for everybody. And the way it's put now, I think you need to lighten up a little on this.
Ms. Kirkmeyer.
I think that what we could do is we could change it to where we said that we would, that it needs to have provided an adequate funding. Examples of this could be, but because I do think that they need to understand what examples they need to be looking at. So we can put in then, require an additional fee for all licensed individuals who prescribe or dispense, and give the information there, as well as looking at, and this will have to be the board to decide, and looking at pharmaceutical companies and the public. I mean, we could put kind of like an EG or including all of these entities, so they can look at however they want to write the language when
But
they're
also
looking.
putting the onus on the dispensing pharmacy to be the trigger alert.
Can we
instead of making it on the physician who prescribes?
I'd like to separate the two issues.
No, I understand that, but that may actually have an impact on the funding of the.
I will tell you that there are emergency physicians are very anxious to be able to have rapid access to this system so that they in the moment when someone comes into an emergency room, that they have the ability to check on cures. This American College of Emergency Physicians has made the case in multiple states that this is very important for them. If it's your own practice, you know your patients, you know that you're seeing this person over and over. They're not strangers, if you will. It may be a different issue. So I think we ought to. I think the first issue that's called out here is for both the protection of prescribing physicians as well as protection of the public, quite honestly, a rapid response, accurate cures system will enable both dispensing pharmacists and prescribing physicians to have the information they need to ensure that they aren't facilitating drug-seeking behavior or
Right. Yeah, I want to have the information, and I want to be able to look it up. I just don't want to come back and be penalized if I was not able to access it for whatever reason. The internet was down, cures wasn't working, etc. I don't want to be responsible for that, but I want to have access. But at some point, someone has to be responsible, just like Ms.
And for physicians who cannot afford whatever until they can, you know, this might be an opportunity to get us a backstop where you require the pharmacist, dispensing pharmacist, that's one more protection to catch something in the event that a physician can't afford the access to the system.
So have you gotten enough information on this?
Yeah, I think so. I'm going to stop here, so that will be our second group, because these are the 3 items, and I think that we do need to pull these separately, or we can at least include the first 2 and do the physician requirement to check for schedules 2 and 3. I think maybe we should separate that one out and do it under a separate vote.
Well,
yeah, we could.
I think what you're hearing is a big pushback at this point on mandating physicians.
Yes, so that's why I think we should pull that one separate from the other 2 moving forward.
Okay.
If you're okay with that.
All right, so
Okay, so at this point then, I'm going to try to say this. I think Letitia's taking notes for me. So at this point then, I would like to entertain a motion that the board move forward with coroner reporting and changing the layout on that one to make it more neutral wording, and moving that forward with changing it from the way it's written right now in kind of making a lot of assumptions to more neutral wording, and moving that one forward. For the CARE system, moving forward with a revision that would say that the system needs to have adequate funding would be provided. Some examples of what you would look at in that would be the additional fee for an individual who prescribes or dispenses, pharmaceutical companies, or the public. We would rewrite that one to say that, and I would like to entertain that motion first and then separate out the second one, if that's okay with
do I have a second?
President.
Second. Public comment on Yvonne? Ms. Chung?
Yvonne Chung with the California Medical Association. Regarding coroner reporting of prescription drug overdose, we would recommend, considering the position, or at least the discussion that the board's been having, the recommendation seems pretty strong in that it proposes a very specific solution. From what, just based on what we heard, we would recommend perhaps change the recommendation to make it contingent upon more data and study and educating coroner's offices on their responsibilities, rather than jumping immediately to a recommendation that that the coroners report all deaths to the medical board. Several of our concerns regarding this, again, as Dr. Ganadev said, it is a significant workload increase. That's a lot of cases for the board to investigate. In addition, on the part of physicians, if you are investigating every single overdose, just the cost of physicians in responding to those investigations, knowing that a very, very small percentage of those are likely to be found to be inappropriate prescribing, that's a significant cost in time, cost on physicians. And finally, removing responsibility for investigating these cases from the coroners. it seems like we're taking it further away from the source. It seems like the coroners are probably in the best position. They're the ones there who are actually doing the examination, rather than taking the medical record and then farming it out perhaps to an external reviewer to review. It seems like you're removing, it's going to make it harder to determine whether or not inappropriate prescribing occurred rather than easier. On the issue of the cures funding, we agree with everything you've said. We agree that it should not go on physicians. Our concern about laying out, even sort of offering up physicians as one of many sources of funding is that, as we know at the legislature, often they do what is easy and not what is right. And so it may seem really easy to just tack on $5 to a lot of licensees, when really what we need to do is make a greater effort to perhaps go after pharma and some of the other stakeholders in this and really make it a truly shared rather than partially shared. Thank you.
Any other public comments on these two recommendations?
Good afternoon. I'm Lisa McGifford. I'm with Consumers Union's Safe Patient Project. And regarding the recommendation on the coroner's reports, our feeling is that the board needs as many tools as they can to oversee physicians, and we think that this is a good idea to get this kind of information to help identify if there are some trends or some commonality, if there's perhaps a physician whose name keeps coming up. Those are the kinds of things that we think it would be very useful to have this information, and we would support passage of that. Thank you.
Two other slips on Section 5. Julie, did you want to comment on these?
Please. Just very briefly. Good afternoon. Julie D'Angelo Felmuth from the Center for Public Interest Law. We absolutely support the proposal for required coroner reporting of prescription drug overdose deaths. Yes, there's been a call for data, but you're not going to get the data unless you get coroner's reports, and you're not getting them. When in 1990, we wrote a bill requiring, creating Section 802.5, which requires coroners to report deaths involving negligence, or there's one other, I forget what it is. And they begged us, the California Coroners Association begged us to require them to report and to give them full immunity for reporting. And we included that in the bill, believing that it would lead to coroner reporting. But it hasn't. Last year, you got a grand total of 4 coroner's reports. So absolutely, the federal government has declared this prescription drug overdose deaths as an epidemic. Prescription drug overdoses are killing more people than street drugs. And that may be anecdotal, but that's what I'm hearing from the federal government. And you're not going to get this data unless you get coroner's reports on prescription drug overdose deaths. Thank you.
And Teresa Anderson? I don't want to overlook anyone. Okay. So, we have a motion. I'll call the question. All in favor?
Aye.
Opposed? Abstentions? That was weak ayes, guys. Aye.
Without objection.
Okay, great. And
Then the second issue would be whether we want to move forward with considering the physicians be required to check the cures, and I think I'm hearing that there's not a decision to move forward with that, so I don't know if, Diane, do I need a vote for that, or can I just remove it?
no, you can remove it.
Okay.
They haven't made a decision on it. You have no motion.
Okay. And then I would entertain a motion if there were one
To remove.
I'll second that.
Public comment? All in favor?
Aye.
Okay.
Okay. All right. Figure out where we are. Okay. Then now I would like to move on to the enforcement and consumer protection enhancements. If you look on page 165 of 400, this is the public disclosure of malpractice settlements. Currently, the law requires the posting of malpractice settlements if a physician has 3 settlements in a 10-year period and he is in a low-risk specialty, or 4 settlements in a 10-year period in a high-risk specialty. The public would be better informed if all malpractice settlements over $30,000 reported to the board were posted. The recommendation is to post all malpractice settlements. And it's there before you. Are there any questions?
Yes, it's there,
The 30,000 originally was a trade-off for something. 250. It was we put that number 30,000, and we got something in return about something.
I think you're thinking of micro, but I don't know if that was part of
Micro
that.
is the $250,000 cap on.
So we got the $250,000 cap
No,
as a
micro's
result
not.
for having 30,000, right?
No.
No, micro is not a function of. Micro is a function of civil litigation, and this is an administrative realm. So, I would respectfully say micro is not in play here.
This number was a negotiated number, and it had to do with the fact that there are often small settlements in the absence of fault finding, and that the feeling was that a $10,000 award essentially where there's been no fault found, but there is compensation, if you will.
Frivolous, I believe.
Right.
Frivolous.
But where I was going was, is that number too low, and should that number be higher now, given that 10 years ago, the value of $30,000, are we, I'm suggesting that maybe that number should be higher.
It's not just about the number. I think this is, if you look at, I'm the medical director of a public hospital. I do get any malpractice suit in the hospital where I attend the board of supervisors meeting on behalf of all the physicians that are at the hospital. There's so many settlements are nuisance settlements. And so what are we trying to do? I think it's just because the cost of litigating often is anywhere from $30,000 to $150,000, depends upon the case. Just to get expert witness testimony alone costs that much. So what the liability companies will ask you is pay at some nuisance value and move on. So just putting that all on that website, it just scares me to death. I don't think we are providing consumers, we are giving information which is not totally accurate, because there are some settlements where it shows how negligent the physician is, and we should provide that information. But there are some things which is just so nuisance. Actually the insurer almost forces the physician to settle because it will cost more. So if that is so, how is the consumer going to differentiate? So I don't think it's a good idea.
Dr. Salmonson?
Well, I just would support that, because the concept is we presumably will have investigated those reports, right? So we're going to be getting that, and then if there was cause for discipline, we would have proceeded with that. So it's not like we're suggesting that the board not be informed of all, but to put that, I don't think adds additional public protection, because they can't differentiate the nonsense suit. And quite honestly, the latest strategy, and thank God I haven't been subjected to it, but colleagues that I highly respect have, so I say I'm the lucky doctor at this point rather than the better than they are. But the strategy now is that malpractice attorneys is don't even charge malpractice, charge a criminal offense like assault, so that then you will extend to the malpractice settlement, so you'll get coverage. And so more people are being forced to beg their carrier now, okay, rather than fighting it, because the threat is that it's going to be a criminal offense instead of a malpractice case, which they won't have insurance against. So they are even increasingly accepting payments. So it's even less accurate that a payout was anything other than just a way to, frankly, move on with your life.
Any other comments? So I'm hearing concern about this, and I remember the negotiations that went on around this number, 3 for low-risk specialties, 4 for higher-risk specialties, and it was over multiple years, I think, this piece of legislation took because of the concern about the valid or the information value of single settlements posted on the board. So, yes.
So I'm fine with having the multiple. My question was, should we raise the dollar amount from 30,000 to something that's more in line with nuisance versus reality? And I don't know what that number is. It was feeling to me that 3 cases of $30,000. Is that what for whatever? $30,000 just seemed to be like a low number that you were going to get. I mean, how many cases have we had that?
I believe that number comes from the National Practitioner Data Bank.
So that you need to leave that number there?
That's the number that requires reporting.
Yeah, it's from our statute.
One of the things I think I'm hearing is that we actually don't have enough information to make a recommendation about changing the dollar amount or the eliminating the number of cases. Or
well, you said the statute. What we're going to do is look for laws. Isn't that what this whole business is about? So if we're going to look for laws and we're going to change the laws, then should we be looking at it again or not?
So legal
I think
counsel,
that goes back to Dr. Levine's comments about the amount of information.
So legal counsel says the dollar amount's not before
I don't believe I would kind of ask the board to exercise kind of care and caution here. I'm not sure that revision of the $30,000 is before us. I think the issue is before us is the posting of essentially any settlement. So,
I already commented it's a bad idea. If you take high-risk specialty, orthopedics, neurosurgery, emergency medicine, anesthesia, the OBGYN, if you haven't gone through at least one liability settlement, you're lucky. It's not about good. You're just lucky. So that's not what we're looking for. Not looking for luck. We need to really inform. I think that numbers you came up with before were negotiated. I think between the doctor groups and the medical board and the legislature to really come up with that. If you want to change anything, I think you got to go back to the same route to really see if there is something more in there. And Mr. Yaslovsky's comment about $30,000 is also an important item to when you go back to negotiations that way.
But we're not changing the amount. I think council just told us that we're not changing the amount. It's just the frequency of the reporting.
Right.
Why aren't you saying that you're requesting we ask the legislators to change the amount then?
No,
what do this at all?
What I'm asking is, if we really want to do anything with it, take everything into account. That is the amount, the number, and everything else, and the high-risk specialties, and then work with the involved groups, and then really come up with something rather than fight in the legislature. That's which doesn't take us anywhere other than that we put forward something and it goes nowhere.
It would also be helpful, I think, for us to make a reasoned judgment to understand what has happened since the legislation went into effect. What is our experience? How many settlements have been 1 versus 2 versus 3? So before making a recommendation to the legislature, it would be helpful to look at our own experience with the reporting and see.
Well, this may be just a kind of a corollary of that, but like an internal audit of all of the malpractice reports that we get. What percentage of those, after they've gone through investigation, are felt to be warranting of discipline?
Julie, did you have a comment? Thanks. Oh,
Julie D'Angelo Thelma from the Center for Public Interest Law. Thank you, Dr. Levine. Just a quick bit of history. The $30,000 figure came from the reporting requirement, which was put in the law probably 25 to 30 years ago. Insurers that pay out on malpractice claims, settlements, physicians themselves or physicians counsel must report to the board all malpractice settlements in excess of $30,000. So that's where the $30,000 came up. And what it resulted in was a whole lot of settlements for $29,999, which you never will know about. The issue then became, 15 years or so ago, why is the medical board receiving all this information about medical malpractice settlements but not disclosing it to the patients? And you may be surprised to learn that over the past 15 years, this board has gone on record at least 2 times, if not 3, as supporting this exact proposal. Just go ahead and post all malpractice settlements that are over $30,000. Under the law, there has to be a huge disclaimer whenever the board posts a settlement. It's in 803.1D, and it is disclosed. Under the law, the board can't report the exact amount of the settlement. Instead, it has to do this complicated computation of whether it's above or below the average amount paid by physicians in that same specialty. So I'm not sure where staff is on whether you would retain all of those limitations, but I think you just want to get rid of this 3 or 4 depending on the specialty. One last thing. After the Enforcement Monitor project was over, the California Research Bureau, which is part of the California State Library System, did a study on the public disclosure policy of this board and whether it's adequate to protect the public. And the guy who did the study found that, particularly in this area of disclosing malpractice settlements, that the board could and should do more to disclose more settlements. So I think that study probably supports this particular proposal. Thank you.
Ms. Salmonson.
Well, the other problem it doesn't take into account is how busy an individual's practice is. And I just know that I've sat on the occasional credentialing board for hospital or surgery center or whatever. And, so there we see every malpractice report. And after a certain level of busyness, you just can't find somebody who hasn't had a case. And I think the public might not understand that component and may falsely think that person has a little black mark against them, which would be, in my opinion, knowing their work. When I see, wow, that person has it, it's in closed session, and it's totally explained what it was, and it's like, well, you see, they just said settle because I don't want to fight it, but boy, I think the public would actually be harmed by that information, and you might not think that would be the best person to go to. And I would say that often people I refer to.
So I'm going to ask,
always, I want to associate, I agree with Deb. I mean, as a municipal lawyer, we see a lot of settlements, and there is a push for that at times, just because of the nuisance aspect of it. And given the issues involved here, I would agree. Now, I hate to punt things, especially when they ask us to do it, right? And I do want to give a reasoned recommendation. But given the sensitivities in this instance, I do think framing the issue and asking our stakeholders and our friends in the legislature to help us and give us some guidance here may be of benefit. Because the $30,000, whatever it's clearly low. Then you're going to have people doing settlements 1 nickel below it. I mean, I don't know that what's before us right now is going to fix anything or be of benefit to the public.
So I'm going to ask for a motion to withdraw this and have staff actually do some more research on what recommendations have been made, what our experience is, and come back in January, remove this from the Sunset Review, but bring it back in January so we can have a further discussion of what in fact it is that would truly provide value to someone.
I'd be in support of making that motion. You articulated it. I'd like to make that motion, that more research be done to how to better use the malpractice information that we receive as a board to appropriately report to consumers to give them valuable information.
Great
based on more
phrasing. Can I have a second on that, and then I'll open it for public comment?
From Dr. Bishop.
Okay, Dr. Bishop, thank you. Public comment on this.
Lisa McGiffert with Consumers Union Safe Patient Project, and we'd like to speak in support of this, and we understand you've just moved to bring it up next meeting, and we'll try to be present for that. But this is, this is generally public information. It's just not gathered in a place where consumers can find it, and consumers are going to come to the medical board for information about doctors. And we believe that this is pertinent information. I think the public is smart enough to figure out the doctor that has one of these cases against them versus the doctor that has 20 or 10, and that's what's being hidden from the public view. So we would definitely encourage you to consider to move this forward, and look forward to more discussion about it.
Thank you. Any other comments?
So, Madam President, just to understand the motion, I apologize, and so withdraw this
from the sunset
for the
review.
conclusion of the sunset report, and then bring it back before the board with a comprehensive discussion about how it can be made more informative to consumers.
Yes,
okay.
that's correct.
Yvonne Schoen with the California Medical Association. We are in support of the board's motion to bring this back. We agree there is not enough information at this time, and it makes a lot of sense to really take a close look at how many of these malpractices actually do result in some kind of discipline by the board. Thank you.
Thanks.
Yeah, Chair, can I ask a question? A statement I think was made, but I don't think that's accurate. This is not readily accessible public information. You cannot access a National Practitioner Data Bank as an individual, and there's no real way to access settlement information, because most of the time they're made confidential unless a regulatory agency requires them to be reported. So,
I was referring to it like the county, at the county level. In most places it's available. You can go and look up the case and read about it in the county, but you just can't get it.
you can look at the case, but the settlement may not be disclosed.
Court involved.
Some settlements are very confidential. Yeah.
Isn't there mandatory reporting of settlements over $30,000?
Just to the medical board,
Just the
but we
medical
keep
board.
those confidential unless we take disciplinary action.
So the public can't get them. So.
But they may be able to get some information from the court.
Okay.
Okay, then moving on, the next one.
Forgot to
Oh,
vote.
sorry.
Okay. All in favor of the motion?
Aye.
Any opposed? Any abstentions? Okay, thank you.
Okay. Moving on to medical malpractice cases for no upfront view, and that would be page 166. The board is required by law to submit all quality of care cases to an upfront medical reviewer prior to the case going to the field for investigation. There are a few exceptions to this. The exceptions are that if there is an 805 filed, if a physician is subject to a pending accusation or ongoing investigation, and those are the exceptions that we currently have in statute. The malpractice cases have already been reviewed by a number of experts. Additionally, if the board needs to subpoena the records, which happens on these cases, the case is sent to the field, but it must then be sent back to the central complaint unit for an upfront review to comply with the law. This is not efficient and wastes time. The board would recommend an exemption for malpractice cases from the upfront review required pursuant to Business and Professions Code 2220.08.
So could you explain before we take comments exactly what would be different? So what would happen if this goes away?
So right now, if we have an 801 case and we determine that we would need to subpoena the records because for one reason or another we can't get a patient release, if that case were to go out to the field for investigation on that subpoena or to obtain those records, once they get those records, then that case would be able to remain in the district office for then further review of that and determining whether there was a violation of the law. We would still conduct our normal triage on these cases and look at them before we would send them to the field, but this would actually not require that upfront review at the central complaint unit as we're required right now. We have that expert review, so those cases basically right now would be able to gather all the information and send those to the field if there was a violation that they found.
So, right, so you're not eliminating expert review, you're eliminating redundant expert review.
We're eliminating 2 of them.
Okay. Does anybody have any questions about the process?
Yeah, I just have one. How many of those cases after our experts review were not pursuing investigation compared to if you send them all? So what percentage are going out for investigation of the current malpractice cases?
I would have to ask our chief of enforcement if she has an idea about that. Off the top of her head, I don't know if we've
Off
been
the top of my head, I don't have a number. For the number of cases that result in being referred to
Renee, could you?
the complaint unit, from the complaint unit to the field.
Could,
Come to them, then talk.
were you clear on Dr. Gananadev's question?
Well, I'll ask him to repeat it just to give me time to think.
Okay. Could you repeat the question?
Yes. Yes, Mr. Agnew. Out of... My mom is telling me. So it's how the number of malpractice cases you get reported. We send them to our own expert review, it looks like, and then we investigate. Is that what I'm hearing?
You're asking about the upfront review, how many of those cases following an upfront review go to investigation? That would be quite a few. I'd say probably as many as 50% of them.
Okay, so what I'm trying to see is, are we just eliminating redundant review, or are we eliminating something which adds value, which doesn't increase a lot of workload on the staff side? I'm looking at, if you send everything out, but if you're eliminating 50% after our expert review, we're adding all those 50% back to investigation. So that's why I just want to know what percentage.
Is what Dr. Gananadev describes accurate? In other words, by removing the upfront review, would you actually be investigating twice as many cases?
Right.
Maybe if I can go back in time, actually, this might help. Prior to this statute, if a case came into our central complaint unit, we would gather all the information and we would look at it at that point in time. And some of those cases, we wouldn't have a review at that point. We would send them out to the board anyway.
Right.
It would almost go back to that format that we used to do prior to this requirement. But at the same time, there could be cases that come into the central complaint unit, they look at, and they don't go to the field. That prior to this statute being implemented, that process would come into play again.
Right, and you're correct. What we're trying to do is eliminate the redundancy in having specialty review on these cases prior to them going out to the field. And once they're out in the field, they're going to be reviewed again, maybe even by 2 separate specialty reviewers.
And one of the biggest problems we have for this is the fact that some of these cases, a lot of these cases, we do have to subpoena the records, and that's where the time delay that is caused by this. Because even our own Attorney General's office is telling us, in order to comply with that statute, you do have to send it back to our central complaint unit for that upfront review before it goes back to the field. So that's kind of what brought this to light, just so you know where this came from staff.
So it gets reviewed up front, it goes out to the field, the records are subpoenaed, information's collected, it goes back
to the central complaint unit, and
Right.
then they review it, and then if they need investigation, it goes back out to the field.
Which is adding a significant amount of time.
No, but I got it. Actually, it looks weird. This is more efficient way of doing it.
Right.
Okay. Any other questions or concerns about the recommendation and how it relates to the process of investigating medical malpractice complaints? If not, do you want to?
If we're okay, I'm going to keep going. So the next one is physician availability, knowledge, and training. During discussions at the Committee on Physician Supervisory Responsibilities, it was suggested that the requirement for physician availability regulations in clinics or settings using lasers or intense pulse light devices for elective cosmetics procedures be expanded. The committee believed that to enhance consumer protection, there should be laws or regulations on a physician's availability in other settings where other healthcare practitioners perform these procedures. In addition, the committee also recommended that the supervising physician and other healthcare practitioners have the appropriate knowledge and training in order to perform the procedure and supervise those performing the procedure. The board would recommend that legislation be passed requiring regulations be implemented to define physician availability in other settings and also outlining a physician's training and knowledge needed when supervising other healthcare providers. And again, this is actually a recommendation out of that committee to the legislature, if you remember when you adopted those regulations under the that committee.
This, I agree with the as proposed, but I think there's some language here that doesn't make much sense.
Okay.
I think you combine two issues into one. I think what you really need is require the establishment by regulation of the knowledge, training, and ability a physician must possess to meet the standards for the supervision of other health providers, and in addition, the availability criteria, because those may be different. I mean, someone have great training, but be in Alaska, so I think we want to, there's actually two issues here, both the availability and the skill and knowledge to supervise at all. So those are two related but independent almost features.
And we can word it that way based upon your recommendation. Actually, Dr. Bishop, I'll probably call you.
Okay. I'll forget by then. So
Okay, all right.
Can remind you.
So that what we're looking for is legislation addressing two separate issues, one of which is proximity and availability of the supervising physician, and the second is the skills and knowledge sufficient to actually supervise the provision of the service.
I think it's both are great ideas, but both are separate. They're not
And
same.
Perfect. Okay, all right. Moving on. Notifying patients of a physician's restrictions. Currently, a physician needs to provide a copy of an accusation decision to every hospital where they have privileges or membership and to their malpractice carrier if they have action taken against them. However, there is no notification to the patient required. Some boards under the Department of Consumer Affairs require a licensee to post a notice stating the person is on probation. The board could recommend that a disciplined physician on probation with monitoring requirements provide notification to their patients. Are there any questions on that one?
How?
It would.
No. Go ahead.
Just because it's you got to take it to the how the workflow and everything else is just trying to see. I didn't say the idea is bad, but how are you trying to do?
If you look at the third paragraph down, we were saying that possibly the notification could be provided to the patient in writing at the time of the patient's visit, and then the patient could attest to having received the information, and then that would be placed into the patient's records. We currently have this for some of our requirements for physician notification in our disciplinary guidelines. Usually a female chaperone. Sometimes I'll have to make sure that they notify the individual coming to see them. I can't think of
We have some.
Another
Pardon me. We do have some where you have to notify the hospital or something. There are some flavor in that. I don't know what to do. It goes down to the patients.
Well, I think that the big governing bodies have no problem finding out. It's the patient who, at the end of the day, is the consumer protection who we're after. They're the ones who are going to have the hardest time finding out, because the hospitals and everybody else, they're all going to find out. It's
Right.
just the consumers who.
And that's why we have this before you.
Right. So there's currently required notification of institutions and employers of physicians, and this would be a recommendation that we explore the option of under what circumstances would a physician who's being disciplined and with a monitoring requirement, which is what you've written here specifically, on probation with a monitoring requirement. So
It's only doctors that are being monitored?
No, it's, yes. But any, so it's that, so this is a subset of physicians who are being disciplined, is that correct?
Yes, and I understand what Ms. Yaroslavsky, it almost needs an and in there, on probation and with, so you want him to notify.
So we're not going to have all doctors that are on
And they also have a
probation.
monitoring. So if they had probation and no monitoring, you would want them to be notified as well.
So we tend to monitor things like charts and billing. I'm feeling real uncomfortable with this. I have to tell you, I'm not sure where I'm going, but I'm feeling very uncomfortable. I would feel more comfortable with a notification. I can't speak.
No. I just wanted to alert her that I wanted to say something when you get a chance.
So I'm feeling very uncomfortable with this. Somehow it's feeling inappropriate information. I think consumers have to have information. I think educating consumers of how to get that information, doing a better job of media relations with local press and religious faith-based organizations and PTAs and people that chit-chat and gossip, I think it's a good idea. Seriously, I'm making light of it, but I'm serious. I am very uncomfortable with the idea that maybe posting the sign that a doctor, if you're interested to know if I'm on probation, ask me. I'm feeling very uncomfortable. This is making me get the point. I'm not feeling comfortable with it.
Yeah.
I'm not sure where I'm going, but I'm not feeling comfortable.
I'm in the same place.
Dr. Ganandev?
Yes, thank you, Madam.
I'm not doing a very good job of managing this, but
I'm in the same place as Mr. Yaroslavsky. It is, I think having sexual misconduct, do these things, is totally different than whatever reason this person is on probation. To do that with every patient and get an attestation signed by the patient, I mean, I'm not sure really I want to get there. So that's I'm not only putting consumers protection, I also am putting, I'm a physician, I'm just putting that hat on too. So it just, I don't know what, that sacred relationship sometimes just totally might break down. I mean, there is no more sacred relationship between a doctor and a patient. I don't know where that's going to go. I'm just somewhat lost on this.
But maybe what we could do is put a component in here that we want to explore the opportunities of better informing consumers and bridging that gap between their professional provider and how to do that. I want to remind everyone that Sunset Review is a reason for us to stay in business, and that's all it is, okay? So that we have to fashion the world into a square, I'm not sure that that's what we're being charged here to do. So in the perspective of what we're trying to do, I just starting to feel like we're getting a little bit too,
So is what you're saying that what we recommend, that before we recommend something to the legislature, we need to feel confident that there is agreement on not just the headline, but
why?
The what, the how, and the why. And it sounds like there's some concern that this isn't at that baked yet to that stage.
I'm also hearing that this might not be an option. What you're saying is more education for the consumers, which would actually be something that would fall under the education committee and not go forward to the legislature as an issue.
That's a possible need for a law. I mean, when we have sexual misconduct by a doctor, and a doctor has to have a chaperone in order for the patient to be seen and with a chaperone, I don't remember, and I have a very poor memory, okay? But I do not remember that the patient is at that point to be notified that the reason there is a chaperone in the doctor's exam room is because the doctor has been disciplined. I don't remember that to be true.
There are in some cases where they do have to notify the patient.
Okay, so I'm not aware of that. It's not in all
Not
cases.
Absolutely.
So in that situation, which is the most egregious, in my opinion, or more than maybe not, I don't know, depending. I'm just feeling very uncomfortable with the decision that we are going to breach this opportunity without a whole lot of thought behind it, and it's not so. I'm obviously very uncomfortable.
We could take a motion to remove it. And that
Well, but
would
if
be
you
fine.
feel that this is important, that's what I don't want to do. See, I'm thinking that if you feel that notification of patients, a physician's discipline is an important issue that goes to the consumer protection, the licensing and enforcement of the doctors that we oversee, then I would leave it here, but somehow fashion it in such a way that you feel that this has value as an ongoing project for this board. I don't think there's anything wrong with that.
So separating out recommendation for legislation from an area of interest the board wants to pursue.
And maybe there is something at the end of the day. But I'm
right.
not there. I'm not at the breakfast time yet. I forget the end of the day.
Dr. Solomonson.
Well, I guess I just think, and again, it's putting too much on the board, but if the probation monitoring was happening appropriately, if we could feel confident with that, then I guess I would feel confident that the patients were safe to be seeing that doctor without signing off, I know I'm seeing a doctor on probation. It's sort of a mixed message to me, because if we feel that the patient needs, it's sort of buyer beware, I'm seeing a doctor on probation, I as a patient would say, I don't think so. I don't see how you'd even monitor the patient, because I would think there'd be 0 patients.
Exactly.
And so,
can you mention insurance companies on this deal?
Mm-hmm. Why don't we remove it for now, but agendize it for a broader discussion? Because I think there is another side to this, which is we know from testimony before this board that when consumers have an adverse outcome and learn that the physician was disciplined, had been disciplined or had been on probation, they're very unhappy about the fact that they had no way of knowing that. And so how we navigate those rocky shoals, I think, is important.
Absolutely.
I don't think we want to drop this issue.
Right.
But
Just keep in mind that it took us a long time to get any kind of public notice in a doctor's office that suggested that they were licensed by the Medical Board of California. The whole purpose of that notification in a doctor's office was to try and help patients figure out that there was a place they could go. We're not looking to diminish public protection, but we're looking to be smart about
absolutely
making access to public information appropriate.
I guess I'm just saying, if we think the doctor is so deleterious that they
should be not
need to
practicing.
issue a warning every time they have a patient contact, then I don't think they were candidate for probation. They should have
should
been
be finished.
revoked
They should be out.
and then try to reapply.
Yeah, they should be.
So we'll separate this out.
We'll actually remove it from the report.
Okay.
Okay, all right. The next one is on the next page, consistency and time to provide medical records. So Business and Professions Code Section 2225.5 requires a licensee to produce certified medical records of a patient, within 15 business days of the receipt of the request. However, in the same code section, a facility is afforded 30 days to provide those certified records. This disparity may have been seen as appropriate prior to implementation of electronic health records. Today, most facilities maintain electronic health records, which reduces the time required to retrieve and prepare medical records in response to requests. The board recommends that the law be amended to allow a facility only 15 days to provide medical records upon request if the facility has electronic health records. And this actually came out of our enforcement committee during one of their discussions.
Great idea.
Absolutely. So you want a motion to that?
Yes.
No, we'll take
No,
this
we're
one
going
all
to take
together.
this all together.
Fine, we
All
can
right.
agree on.
Okay.
Okay. Moving forward, the board has noticed a decline in the number of 805 reports received. The decline in reporting may be due to the fact the hospitals are finding problems earlier in sending physicians to remedial training prior to requiring 805 reporting. The decline may also be due to hospitals not reporting. However, because the board does not have jurisdiction over the hospitals, it has no way of knowing the reason for the decline. The California Department of Public Health and other hospital accrediting agencies have the authority to review hospital records. So the board is would be recommending an amendment to existing law to require the California Department of Public Health and hospital accrediting agencies to send reportable peer review incidents found during an inspection of the facility to the board. The board would also recommend a requirement that these entities notify the board if the hospital is not performing peer review.
Could we add something to that? I mean, is it possible to add to that? I'm sorry.
What?
No.
David, did you have a comment? Oh, go ahead. Sorry.
The idea is not only the reporting of that 805, but not to be able to leave working in the hospital as a result of an 805. So, I mean, if the hospital is going to investigate a situation, and in lieu of an 805, the person can leave.
That's already reportable.
It's already,
They should be reporting that under 805,
Okay,
yes.
so make sure that was
If they have a
complete.
pending investigation and it causes them to resign or.
Okay, so make sure that was in there. Sorry.
Clarification, hospital accrediting agencies, are you referring to JACO?
Yes.
Are there others?
Yeah, there are actually 3 or now 4, I think. Yeah, there are the 2 most common ones are Joint Commission, which is the Joint Commission of TJC, and the AOA, HFAP, Health Facilities Accreditation Program, which is on the osteopathic side. But what, Ms. Kashmir, what I'm hearing is that the hospitals are not doing the 805 reporting even though there is a reportable case. Is that what I'm hearing?
We have heard that because of the continuing decline in the number of 805s. This has been an issue that many people have come before us and tried to say that we really need to look into this. We did a study that kind of gave us some recommendations, but we still, even with that study, we weren't able to identify that individuals weren't reporting. They needed clarification on the law. But we have no way of validating any of those statements. We have looked at National Practitioner Data Bank because we've been told that they are receiving reports that were not, that we found that that was not true. So we don't know what we don't know. I guess that's the bottom line of it. And the only way we're going to know is if the entity that actually can get in there and look at those documents and see first if the hospital is even doing peer review or the group is doing peer review. And then secondly, did they have something that happened in there and they did not provide that to the board? We've seen a decline in the number of 805s, but the reason and why we just can't, it's all anecdotal at this point. We do have information that we've received, and I think you'll be hearing it tomorrow, that part of the reason that it could be is that the hospitals are identifying individuals earlier on before it gets to that point, and they are actually sending an individual to a training program that won't require the reporting under 805 because they don't have restrictions for more than 30 days. They didn't fire the individual or anything. So that may be the reason we're not seeing the 805s, because they're not actually taking the action of the 805s, but we just don't know at this point. So this is the only way we can probably.
So this is an effort to get a second source of data to determine whether or not, whether it's a failure of reporting or not.
Right.
Let me ask you, I mean, so that means that either TJC or HFAP, the 2 most common agencies, they have to decide when something is reportable, even though hospital thought that it was not reportable?
Well, if they were out there and they were inspecting the records of a hospital and they found something that they believed this individual was terminated, and when they're looking at it, they would notify the board. Then we would get that information and compare it. Did we receive an 805 or not? And if we did, then we would have to look further into it.
Is it asking them to make judgments, or is it asking them to collect data?
Well, we don't have language written right now, so we'd have to be probably clear that if they were out there and they found some event that they took against a physician, that they should notify the board. We'd have to clarify that in language, I believe, when we discuss that.
Yeah, if that happens, you might have to work with CDPH, because I don't even know we can tell TJC or HFAP to do something as a California agency, because that's a national accrediting agency. CMS can tell them, but so there are a lot of issues here. So the idea is not, I mean, if somebody is being penalized for something they did wrong, which is reportable already, if that's not being reported and we want to know that information, that itself is not a problem. How to do it is going to be interesting.
Okay. All right. If there's nothing else on that one, then I'm going to be moving forward. Okay. Okay. Let's see. I'm sorry. From the date the board, The law requires certain information to be removed from the board's website from the date the board obtains possession, custody, or control of the information, and after that through the end of the period. The information contained in these subsections pertain to a physician's license, which would require removal. Any license or practice or suspension or restriction, any enforcement actions, such as probation, public reprimand, etc., any disciplinary action in California or any other state as described in B&P Code Section 803.1, any current accusations, any malpractice judgment or arbitration award, any malpractice conviction that resulted in disciplinary action. So all of those would have to be removed from the board's website within 10 years. The only items that would remain on a physician's profile, this is current, I shouldn't say only. The reason it's past tense for us because we haven't got to that point yet. This will start on January 1st of 2013. The only items that remain on a physician's profile on the board's website after 10 years are a felony conviction and hospital disciplinary actions that resulted in termination or revocation of a physician's hospital staff privileges. Although the statute requires the removal of the information from the board's website, these records are public indefinitely and therefore can be obtained from the board's office via a telephone call or in person. However, most members of the public would not know to call the board unless they have fully read the board's disclaimers. If the public does read the disclaimer and calls the board, staff will copy the documents and provide them to the public. The board will begin the removal of these documents on January 1st of 2013. While the board understands this information has an impact on a physician, the board also believes the public has the right to review the information and make its own decision regarding the physician based upon the circumstances of the case, including how long ago the action took place. The board would recommend elimination of the 10 years posting requirement in order to ensure transparency to the public. However, we also had a caveat because we don't know if the legislature would take that. Because the language on the date of the activity and when the 10 years starts is unclear. So, however, if the legislature does not wish to eliminate the requirement for the 10-year posting, that it specify a date or have the board do that in regulations as to when that 10 years begins. Because right now we've actually stated when the 10 years begins. We've kind of sat down and looked at the intent of the law, and we've made our own interpretations on that. So. When we begin this January 1st, 2013, but we believe we need clarification if the legislature won't take the removal of the 10 years.
Board member thoughts on, I guess, you're putting forward two options in terms of a request for the legislature.
Right.
Either to eliminate the elimination or the removal.
10 years,
Or at 10 years, or to clarify when the clock begins on the 10 years.
Right. And even that's kind of twofold. Either they could do it in statute or they could tell us to promulgate regulations to identify those dates.
Dr. Summerson?
Well, there I think I'd be inclined to say once that discipline has occurred, I would be kind of in favor of having it on there. And certainly if that's not an option, the concept that, let's say someone was on probation for 7 years, yep, and they were going to count that and they only have it on for 3 years, boy, that's really a buyer beware. So I think once that, and especially since they can still get it by phone, then that's a mixed message. So if it's not totally expunged and it's the information is available, then I should think it should be on the website.
Any other comments?
Okay, moving on. I think you guys are getting tired. I'm tired.
Not at all.
Okay. This is on expert reviewer opinions. The current law requires that 30 days prior to commencement of a hearing, each party must present a curriculum vitae of their expert and a brief narrative statement of the general substance of the testimony the expert will provide. The Attorney General's office has notified the board that there are problems with this section that need to be clarified. First, the legislative history of Section 2334, which is that requirement, reveals that during the legislative process, consideration was given to both sides to exchange expert witness reports. The board requires its own experts to prepare expert witness reports, and they must be produced in discovery. So the first recommendation would require the respondent to produce expert reports addressing each of the quality of care issues raised in the pending accusation. because the AG's office believed that that would be helpful to them in the disciplinary process. Second, the deadline for both sides to make the required disclosures under Section 2334 is only 30 calendar days prior to the commencement date of the hearing. The deadline is too late in the process and as a result can delay early settlement for these cases. Lastly, the term commencement date as used in that section should be legislatively defined. It should be the first hearing date initially set by the Office of Administrative Hearing, regardless of any subsequent continuances of the hearing. So basically what happens is they may say 30 days, but if the hearing gets continued, then it's 30 days from that date, and so on and so forth as it moves forward. The board would recommend amending Section 2334 to provide further enhancements to the time frame for administrative action. Are there any questions or comments on that?
I think it's fair and appropriate for AG's office to know what the other experts are thinking, just like our experts need to provide. So I don't see any problem with that. But these dates, I just want to make sure that there is enough time given for the accused to find experts and provide that info, at the same time not to have the highly intelligent attorneys drag this on forever.
Right.
So that's why you need to figure that out. I think that's important to.
Just a comment about the language in the last paragraph. I'm not sure what enhancement to timeframes means. I think you mean specificity.
It's defined,
Yes,
they need to be defined.
you're right.
Yes,
Better defined.
something that
Provides
makes clear
specificity
what
to the, yes.
specificity to the timeframes. And so currently, the respondent's expert report is not required, or it's required.
All they need to provide is a brief narrative
Okay.
statement of
So
the
you
general
want a full,
substance.
by
We would
requiring
want
a
the
full.
report.
Okay,
I want to put full in there then. Respondent's full expert.
full expert report. Setting a disclosure deadline further from the hearing date. You might want to be more specific, further forward, further backward.
So we'll do cleanup on
Clean
this
up on
one.
the language, so it's pretty clear what the
Yes.
specifics are. Okay.
And we take them from the other section, it's clear there.
Yeah, as long as though the respondent does get enough time to get these experts to review and give, I think it's fair. But at the same time, as I said, that some of these cases we review are just dragged on for so long that it just amazes me why it takes so long to get anything done.
Okay, so that's the end of this section then. Okay, I'd like to entertain a motion then from the board.
So moved.
Wait, whoa. Could you be specific
I
on?
am, I'm going back to start here.
Actually, Kim, I have it. So we've moved forward with the second item, the third item, okay, I'm sorry.
No, sorry.
No. We
Up
move
front,
forward-
I'll help you.
Move forward with exclude 80101 upfront review for malpractice. Move forward with require the establishment by regulation of training, knowledge, and availability of physicians. We would require that health facilities with electronic health records produce patient reports in 15 days. We would require California Department of Public Health and other accrediting agencies to send real reportable events. We'd have to work on language for that one. We would remove the requirement to eliminate the posting of board actions for over 10 years. And number 8, we would have the production of the respondent's expert report and look at defining a specific date for the commencement of the hearing, which would then tell us the number of days that production of information was required.
Okay. Is that clear to everyone what we're voting on? Can I have a motion?
So moved.
Second.
Second.
Okay, all in favor?
Aye.
Oh, public comment, yes. We have some
Some public comment. Slips.
Hilma? Remind me how to pronounce your last name. Balayan.
Hilma Balayan from Graduate Medical Education. I'm an administrator. I wanted to make a public comment regarding notifying patients about the probationary license with monitoring. In the past, we have had residents who partied during their student years and had DUIs and consequently had a probationary license with monitoring and had to pay a lot of money for that monitoring, which was hard on them. And especially for the longer specialties, general surgery, urology, which they're there for 5 years, 7 years, and they get their license, their license after the second year, they still have 3 years or many years to go. And the problem is if they have to disclose to the patient that they have probationary license with monitoring and ask the patient to acknowledge that, like Dr. Levine said, they will get no training because no patient would actually, want to be examined by such doctor. So I just wanted to also give that angle.
Thank you.
Thank you.
Yes. Lisa.
Lisa McGiffert with Consumers Union Safe Patient Project. I just quickly want to go on record about a couple of the issues that you discussed. One was notices to patients when probation is in place, and especially when there's restrictions on their license. So a physician is still practicing but has some restrictions. We believe this is so important and critical to patients to know when these situations are present. I think I appreciate you bringing up people that have come forward to this board who found out later that after being harmed that the doctor was under some kind of disciplinary action. It's just really important for people to know it, and I urge you to work through ways that you can do it. There might be times when physicians aren't going to be honest with their patients and disclose what they should disclose, but if there was a law in place, they would at least know that it is required. I mean, what it comes down to is, whether you would want to know about it, your doctor being on probation and certain restrictions because of certain conditions, and I think that's what it comes down to all of us. As far as eliminating the public information from the website after 10 years, we would urge you to get that law changed or recommend that it be changed because it's still public, and in today's world of the internet, that should be available on the internet and available to the public to be able to see the full history. Thank you.
Thank you. Have I missed it? Yes. You've been very patient. Teresa Anderson.
Teresa Anderson, Public Policy Director for California Academy of Physician Assistants. I'd just like to offer a point of clarification around the training and availability of supervising physicians in terms of legislation and regulatory efforts. For us, I can only speak specifically for PAs, there is legislation and regulation that governs how we're supervised. I would like to add that we, in terms of availability, we're able to be supervised either in person or electronically.
Thank you.
It's my misfortune.
Could you let the...
My name is Harrison Robbins. I'm board certified in facial plastic surgery, in head and neck surgery, and what used to be called ENT. I practiced cosmetic surgery after majoring in trauma and cancer surgery. I have been practicing cosmetic surgery for approximately 30 years. And I am here to comment on what I think is a significant problem that's easily overlooked. And I will be as brief as possible. I just have 10 suggestions to make about it, and I'll read them. It's like on a list. But we have been meeting and I'm a member of the advisory committee that has been looking into the advisory committee for the medical board that's been looking into this subject. And I've been on that committee for 5 years, and we've had 4 meetings a year, and spent a lot of time and a lot of effort and a lot of different positions and interpretations of what we can and can't do, and so it's been a real learning experience. But I'd like to remind everybody that the California Medical Board, the reason that this is a significant topic is the California Medical Board classifies the procedures of laser and IPL resurfacing as invasive. And the reason that it is invasive is because the laser treatment penetrates the skin and possesses potential for certain known and acknowledged risks, some of which are, and they are in the same 3 categories as all other risks. Some of them are rare, some of them are common, some of them are anticipated. Some of them are mild, some of them are medium, and some of them are very severe. And they can be caused by the procedure itself or by ancillary medications that are used with the procedures, such as topical anesthetics, which have been responsible for death when left on the patient for too long, and blindness from improper care of wearing the goggles necessary during these procedures. We have, as an advisory committee, submitted to the medical board a paragraph after much deliberation that would satisfy SB 100, which has been coded in whatever the code number is. It's Section C of the Business Profession Code 2023. And what they asked for was to determine the availability of a physician to medically supervise the procedures that are being done by other or allied healthcare providers. And you stop me if I'm getting too long-winded.
Yeah.
Please. And all I really am interested...
Little red.
Oh, I see. Thank you. All I'm really interested in is I have 20 copies of what I wanted to present. And I just want the panel to read these, understand the risk involved in these procedures, and understand that at the present time, there is no definition in an office setting of who is actually responsible if there is a adverse event or complication. There may be a doctor's name that is applied in the office. However, often that doctor is doing anything but supervising. He may be remote, and he's the one that's going to be, the patient needs someone to be accountable. And if that doctor has not seen that patient ever, then we are allowing this sort of practice without even, say nothing of physical exams, say nothing of medical records. We are allowing and kind of condoning an MD to be accountable for whatever goes on during that procedure without ever having met the patient. And that's just one of the 10 suggestions.
Thank you very much.
Thank you for giving me...
And if you could, Mr. Einer, the copies, if you could give Mr. Einer the copies of...
I will do that. Thank you.
All right, we have 4 more issues to go.
We didn't vote. Okay. We have a motion All in favor?
Aye.
Any opposed? Any abstentions? Okay.
Okay. Issue number 1 of 4. Unless physicians are certified by a specialty board as defined by law, they are prohibited from using the term board certified in their advertisements. The law allows the board to determine if a specialty board has equivalent requirements to those required by the American Board of Medical Specialties. However, the board does not have expertise on staff to perform this function. The board would recommend elimination of the board approving specialty boards equivalent to the American Board of Medical Specialties, leaving those that are currently recognized as approved for advertising purposes. Any questions?
Just want to be sure that everyone read this and understands the issue.
Yes, I agree with you. I think we shouldn't be in the responsible party to recognize unrecognized boards by the ABMS. That's what you're asking, basically. I know we do have some, but I think it's time that we stick with the National Accrediting Agency rather than create our own accreditation process all over.
Okay.
So with this recommendation, deleting this provision for the medical board to take responsibility for approving non-ABMS boards, the only individuals with a medical license who could advertise themselves as board certified would be those who have board certification from ABMS boards or the grandfathered boards that, okay.
We have approved.
Okay, so that's what you're asking for, okay.
Issue number 2, medical assistants are unlicensed individuals who perform non-invasive routine technical support services under the supervision of a licensed physician in a medical office or clinic. Medical assistants may obtain certified status through private agencies approved by the board. Although certification status is not a state requirement, certain medical malpractice insurance carriers may require its insured to only employ certified medical assistants. The board continues to receive a high number of inquiries regarding what technical supportive services a medical assistant may or may not legally perform. The board would recommend the requirement that all medical assistants be certified by an approved organization.
Is this just a question, is this in response to the question of what can they do? Because a certification program is not necessarily going to answer the question, because anyone who's going to certify it's not going to be a state-based, right? So it's not going to solve the problem that a scope of practice definition issue. I'm not sure how you would approach that, but this is not the solution to that. I guess what I'm asking is, what is the basis of the recommendation for certification? What problem is it solving?
Actually, mine even goes even further. Do we have any information that, like some of these MAs who have been working in a doctor's office are significantly, without certification, are at more risk of danger to the consumers compared to a new graduate who just comes off and get certified by some private agency, not by state of California. So, I mean, my entire point here is show me some science before we make some decisions. If there is, I think I'll go with you. I have no problem, but we need to know what the numbers are, where we are, what it is. I mean, if this removes a person who has been a medical assistant in a doctor's office for 15, 20 years, young woman with 3 kids, and if she loses her job even though she's good, it just doesn't make sense to me.
What was your logic behind having them be licensed in terms of who were you guys thinking was going to license the state certified? I'm sorry, was it like the state of California, or did you guys have something like that in mind already, or
The certifying agencies that are approved by the board.
that are approved by the board? Okay. So there are certifying agencies already.
That have already been approved by the medical board.
Correct.
Are there currently medical assistant programs that are certified by approved entities by the board?
Mm-hmm.
So back to what is the problem here? That you're getting phone calls asking who's certifying? I mean, what is the problem that we're trying to fix here? Either you have a certification program and people that work in that as a medical assistant are certified or they're not certified. Is that the first question? Have issue or?
Well, right now they don't have to be certified.
So one can be a medical assistant and not be certified, or one can be a medical assistant and be certified.
Right.
And the ones that are certified are paid more money than the ones that are not certified.
No.
The ones that are certified have different responsibilities than the ones that are not. What is the difference between, what does certification get somebody?
We really don't have data that says one is better than the other.
Right.
That's
Yeah,
what
we
I'm
don't.
looking for. I mean, that's why.
It sounds like it may be just some employers, some physicians want, rather than having to do that training themselves of the person working in their office, they would like they may be calling saying, where can I get an MA certified?
I don't have any problem. My problem is the other way around. That is, if a MA, medical assistant, is working in the Dr. Joe Blow's office for 20 years, she has no certification. Very good employee, does what all she does. And I also mentioned I have 3 or 4 kids. So we're going to eliminate that person's job by doing this, even though that person is good. So I wasn't sure where this is going. If you say require, mandate that you need, even though they've been doing the same job for 20 years.
Well, I think the analogy would be phlebotomy. The analogy would be phlebotomy for years.
Do they do that?
Just a second, because I'm kind of addressing him. The analogy would be phlebotomy. Doctors' offices employed people for years. They could draw blood. And you could take actually basically anybody off the street and teach them how to draw blood. The difficulty arose is that there was no standardized requirements to protect patients as to really who could draw blood. And so those phlebotomists who had been doing it for a period of years, there was provisions for them to be grandfathered in, provided that they could demonstrate the skills that were needed to do it. And this is, just one more thing about patient protection. The problem is you can call anybody a medical assistant. And I would think that in some clinical settings, physicians would be concerned that when someone walks in and says, I'm a medical assistant, if they've not been certified and that's not the requirement, again, you're back into the same situation as the phlebotomist. And that wasn't done by people coming up with stats about people being hurt by phlebotomists. It was just simply because the invasiveness of what I would think both medical assistants can do with injections and some other procedures, that you'd want to make sure that they were qualified to do what they're doing, just as we do now for people who draw blood.
If you come up with a grandfathering clause, how it can be done, I don't have an issue. I mean, you're trying to create something, but at the same time, do not let go of people who have been doing these things.
And Deb, I think we just did this on the polysomnographers, semonographers, if I can pronounce it correctly. We allowed grandfathering in because those people really didn't have a certification and they've been doing it for years. So as not to exclude them from being able to be certified.
So let me just ask you, so what this law is saying, that of the people that are doing this job, physicians have to supervise them, and in fact, they've got to be present at the facility that they're working at. And then we have to take a look to, if there were to be a certification program, that those that were doing the certification program, in fact, was a reputable organization. Is that correct? And we're not starting a whole new industry here.
Yeah, it's approved by the board, but if we
They're
don't
already
feel
certified. These people are already certified
approved by
anyway.
the board.
So
Yeah.
it seems, yeah.
If we don't feel comfortable moving forward with this recommendation, we can remove it.
No, I think it's a good idea. No, it seems.
Well,
yes.
Okay,
Well,
with the
my
grandfather
only
clause?
concern would be that a lot of these people, like where I work at, there's a lot of medical assistants. Most are not certified because it's not a very high-paying job. So the certification can be a burden for them. So I don't know how expensive the certification is for the medical assistants, who oftentimes are young, single women with lots of children. So I don't want to impose a burden like Dr. Donovan suggested either.
I would put this in the category of it'd be helpful to have more information before we recommend mandating certification. Information about what the training is, how much it costs, or what the certification is.
Yeah, and what it means, because we have some that are certified and some that are not, and they just work just equally, just as good, because it's the experience that makes them
Most medical assistants are trained on the job.
on the job.
Based on the specifics of the practice setting anyway. So is there support for
More information.
pulling this for now and getting more information?
That's okay. Right. Thanks. The next issue is discussed in the RDO program Sunset Report under Section 11, New Issues in Appendix 3. So go to tab Appendix 3, either by bookmark or tab, and it's pages 18 and 19. Right?
Say that again. Section?
Section 11, Appendix 3, pages 18 and 19. The Registered Dispensing Optician Program is comprised of registered dispensing optician businesses, spectacle lens dispensers, and contact lens dispensers that are employed by those businesses, and non-resident contact lens sellers. State Board of Optometry, at its October 19th board meeting, approved its Sunset Review Report with edits, including their interest in transferring the duties, powers, and jurisdiction of the Registered Dispensing Optician Program from the purview of the board to the Optometry Board. Some consumers incorrectly assume that optometrists and opticians are the same profession, resulting in confusion as to which agency a complaint should be submitted. Transferring the program to the Optometry Board will lead to more efficient investigation of complaints by eliminating the need for two agencies to investigate the same complaint when it involves an optometrist and an RDO program registrant. The board would recommend transferring the RDO program to the Optometry Board.
Great idea. Any comment from board members, concerns?
No, I don't want to keep it now. I have one comment, that is, sometimes when this happens, scope of practice issues come up. If someone comes up that ophthalmologists cannot supervise these people, I will have a serious issue. Only optometrists can, but ophthalmologists can't. That's a serious issue. So we do need to deal with that with the Optometry Board before we transfer, because many of these people might be employed by ophthalmologists.
We hadn't thought about that.
None of neither the contact lens dispenser or the spectacle lens dispenser require supervision.
Okay. So these are independent practitioners.
Independent businesses.
Independent businesses, yes.
Dr. Bishop?
This is irrelevant to the matter at hand, except under Appendix 3, Registered Dispensing Optician Program, the first listing is background and description of midwifery program. And that's under a couple other of the appendices as well, so you might
That was on the computer, right?
Yeah, I just want to point out this is
It was in there, yeah.
Could you give us specifics on that?
I have page 371 on the Adobe page. Okay.
It was in the computer edition, but not in the print edition.
Right.
Okay.
I think. I mean, I read it in the computer. That's why I stopped reading the computer. I did, yeah, I read it fast. But no.
Okay, great.
And also to note that when you take public comment, I understand there's someone here to speak on this issue. Okay.
We have one more.
Actually, if you look at Appendix 2, the page itself says background and description by, it should be polysomnographic, it says midwifery. See, there are places.
Right,
Yeah, and
there's a lot of midwifery there.
it's on each one of the appendixes, midwifery is listed.
3.
So 1, 2, and 3, as I remember.
They just wanted to make sure
And
we
4,
paid
it's on
attention
4.
to it.
That's right. So actually, midwifery is not going to do all of that.
Ms. Yaroslavsky, you have passed the exam.
So my practitioner midwife. See, I got the glasses.
We have one more.
Okay. All right. The last issue encompasses 3 items discussed in the midwifery program Sunset Report under Section 11 New Issues in Appendix 1. Go to the tab or bookmark Appendix 1, pages 14 to 16. The first item is the requirement that midwives have physician supervision. Midwives have difficulty obtaining physician supervision because most medical malpractice insurance carriers will not insure physicians who supervise midwives. Previous attempts to resolve this issue have been unsuccessful. In 2006, the board adopted regulations outlining the standards of care for midwifery. It appears the physician supervision requirement needs to be addressed through the legislative process. The second item is the midwife's ability to order laboratory tests and obtain medical supplies. The board's position is that licensed midwives, as licensed healing art practitioners, are independently eligible to open laboratory accounts for medical diagnostic testing within their scope of practice. The board's midwifery standards of care states midwives shall order or administer only those prescription drugs and procedures that are consistent with their professional training, community standards, and the provisions of the Practice Act, and shall do so only in accordance with the client's informed consent. The Midwifery Advisory Council has held meetings regarding these issues and attempted to create regulatory language to address these issues. However, based upon discussions with interested parties, it appears the lab order and medical supplies and medications issues will need to be addressed through the legislative process. The last item is the midwife student, apprentice, and assistants. There has been disagreement between the board and some members of the midwifery community regarding what constitutes a bona fide student. However, the current statute is very clear regarding a student midwife. Some members of the midwifery community hold that an individual who has executed a formal agreement to be supervised by a licensed midwife, but is not formally enrolled in an approved midwifery education program, qualifies the individual as a student in the apprenticeship training. These types of arrangements are not consistent with the provisions of Business and Professions Code Section 2514. A task force consisting of members of the Midwifery Advisory Council has recently been formed to examine this issue. However, the issue of students' apprenticeships may need to be addressed through the legislative process. Current statute and regulations do not address the use of midwife assistant, the need for formal training or not, or the specific duties of an assistant. Current statute does not provide a licensed midwife with the authority to train or supervise a midwife assistant who is actually assisting with the delivery of an infant. The issue of a midwife assistant is not an issue that can be addressed with regulations with the current statutes that regulates the practice of midwifery. The board will recommend addressing the ongoing issues related to midwifery, including supervision, medical device and drugs necessary for the profession, and students' apprenticeships and assistants. Any questions?
So you're going to bring us back what they are, right? How are we trying to resolve these issues? That's what I'm looking at. I mean, I know these are issues, but I don't see a resolution here how you're going to do it. So that's why I'm just asking.
These would all be brought to the legislature. We would give them this background information, and then as we go through, that language would be then defined during discussions with them. Is that correct, Ms. Whitney?
So you're asking, we get a second bite at the apple. You have a second bite at the apple.
So you're actually going to have legislature come up with solutions, and then we'll look at it? Is that what I'm hearing?
What will happen is these will go to the Sunset Review Committee. They will do a review of the entire package, including our new issues. Then they will determine whether they want to take these on and then come back to us and work on language for the bill that they will be putting forward for our Somerset review. I would assume that there's going to be several bills because I think they'll do one for our state and then one separate for the issues that will be more controversial.
So I'm sorry, if I understand correctly, what's going to the legislature is the fact that the midwives have a hard time finding physician supervision because of the malpractice, and that's the reason that they can't get labs even though they have an account, but because they don't have physicians, and they can't be students, they can't supervise students because of the same issue. And there's nothing we can do, so you're going to bring that to them because we can't fulfill that requirement. Right, that's it. We can't do anything.
No.
Okay, that's what's going back. We're gonna take that back, and then we're gonna say, sorry, we can't do anything about it.
You're going to say the same thing back then?
Well,
It's a good punting strategy.
Catch 22.
We're punting this too.
so there are two things. One is we have a clear sense of what should happen, but we don't have the authority to do it, and so we request statutory language based on a clear sense of what we believe should happen. On these issues, it sounds like we don't have a good sense of what should happen. And in the absence of that, we're asking the legislature to do that?
They're going to say the same thing back. You have to assume that the legislature is not going to have a very good answer, so they're going to suggest to us, you need to come up with some program. So maybe what's going to happen is we're going to have to sit down again with interested parties, for example, the insurance companies or whatever. It's in discussion.
Well, but in fairness, the legislature actually created the ability for lay midwives to operate, and then it was sent to the medical board to kind of oversee. And these are complaints or concerns that have been brought to this board. I've been on the board 5 years, and I've heard these for 5 years because it really. It's a little ludicrous to say we'll let a profession operate, but by the way, nobody will insure the physician who needs to supervise, and there's provisions in other states where the physician is relieved of liability.
That's right.
It's a requirement, but they're relieved of liability, and the biggest issue in this state is that one of the largest malpractice carriers is physician-owned and operated, and that they will not agree that these individuals can carry, that the physicians who help these people can have malpractice covered. So it is a legislative answer because there's nothing by regulation that we've been directed to do, and we can't come back and mandate that insurance companies or whatever. So it is a legislative solution, and the key carrier of this legislation, Liz Figueroa, is no longer in the legislature, but it has to be dealt with. Otherwise, we keep going through this exercise. We hear the report, we hear their concerns. They can't practice. They're on the edge of not really being able to do what they're supposed to do legally. And I think at some point we have to send it back to the legislature.
Absolutely.
Say, deal with it.
Absolutely.
Deal with it. We have no way we don't have any legal authority to do anything, to put regulations in place that would change any of the questions.
I guess I'm just questioning whether we have an obligation to the legislature to have a point of view.
Well, I have a point of view
about what should happen.
I would think so. Dr. Levine, I would think so because it was legislatively directed to this board to have the midwifery committee and to deal with the concerns and issues. It's just as if we're going to make these recommendations about lasers and supervision and things. I think we do have an obligation to send it back in some form and say it's not working the way that you constructed this law.
For one thing, we need, like everybody says, we need data. And I just do feel the times that we've had talks, we don't know what their basically morbidity mortality is. I've never
No, they do.
So we know all that stuff. We do.
Well, but there was this whole flawed system that they acknowledged, and I said, I think if we had, so I would just suggest as a way to proceed, because the insurance is always driven by risk.
Right. The issue here is, as Ms. Shipsky actually did an excellent job of explanation, is that there are certain tools that this profession needs to have, and they have no ability to have it.
But better
So
data collection, so maybe
we have
companies could.
But if they're not allowed to order,
but they can't order the materials that they need.
tests and labs and do the referrals and get a physician to back them up.
That's the problem.
You're going to have a skewed.
So the issue is that since the legislature gave this problem to this board, the object is for this board to come up with some remedies and some discussion points and some partnership as far as professionalizing this occupation, ensuring that there was remediation if there were things that needed to be reported, in addition to making sure there was an annual report submitted to the legislature. They've done everything. We've done everything we need to do. The problem is that now we're like at the wall. What do? Either we go over the wall or we just stand there and we're at a standstill. And the only way now is to punt it back to where it came from. And I start to get It's getting late, and I apologize. I'm starting to get giddy, and I apologize at my flippant attitude, but it's at the point now that we've done what we can do. We really have put the group of midwives through the hoops that they need to put. We need to take responsibility and give it back to the legislature, say, you wanted us to fix the problem. We can't fix the problem. We've tried. We need some help. You need to start mandating some rules and regs. So that's what I think this is actually doing, and it's doing a good job. And Ms. Shipsky,
Because we're at the point for sunset
I thank you for
anyway.
your.
We've got to do so. We've got to resolve
We've tried.
this somehow.
I mean, that certainly was, I was reviewing the record and I saw all sorts of stuff.
Your mic's not on. It's still not on.
Is it on?
Yes, it is now.
Great. I read the record on this issue and I saw immediately, oh no, this has gone back and forth. You know, and I feel for the interested parties because everyone's coming with good faith. Everybody wants to bring resolution. And I do think we have enough data and information where we could provide the legislature, here's what we know, here are some options, you know, here's where we think the fixes can be. It's not the complete, full recommendation that they were probably hoping for, but, you know, given the complexity of the issue, this is the best we can do. But we've got to take this off our list, our to-do list. We've got to put some closure to it, because that's only fair to everyone.
Okay. I would like to entertain a motion to accept these issues for inclusion in the Sunset Review Report. However, the board may, the specialty board elimination approval, the RDO program transfer, and the 3 items within the midwifery profession. You may wish to do a separate motion for the RDO program and the licensed midwife issues, but I leave that to your discretion. Thank you.
So moved. Let's do it together.
Second? Second. Ms. Shipsky.
Public comment.
Public comment. We have Catherine Scott.
Evening, and sorry about that. I'll be as quick, and honestly, the legislature needs one of these. If you can send about a dozen of them to the committee room, they actually do have limits, and it would be lovely if the timer was in front of those who have limits. Catherine Scott, representing the LensCrafters and Eye Exam. I'm here speaking for the comments that were provided to you earlier this evening from the National Association of Optometrists and Opticians. We do have very real concerns about transferring this board specifically to, or the RDO program specifically to the optometry board. For those of you who've been around a little while and understand the differences, RDOs are standalone entities. The majority of RDOs are retail optometrists, LensCrafters, NVI, which is located inside Walmart, Sight for Sore Eyes, and the like. And the board has successfully managed this program with little incident, and we've been very happy with the management of the program over the last, since 1936. No other state combines optometry board with opticians because of the inherent tension and conflict between the two, a lot of it becoming a business issue. So, for example, our chief competitor is a private optometrist, so the proposal would essentially move opticians to be regulated by their chief competitor. So we have very real concerns about that. More or less because of what we've seen in other states when that's been attempted. Again, the inherent conflict between opticians and optometrists. We love working, Eye Exam co-locates with optometrists. We have a very good relationship with them, but as an industry, they often compete for business, and therefore having them regulate this industry would cause concerns. The other issue we have is we are in active litigation related to that business relationship. An optometrist and optician cannot legally have a business relationship. An optometrist cannot work for an optician. So what you're saying is that an optometrist can hire an RDO, but an RDO cannot have a business relationship. So in 47 other states, LensCrafters subleases their space to optometrists, for example. That cannot happen in this state, and there's litigation related to that currently pending at the U.S. Supreme Court. So moving this board could be premature, removing this function could be premature to that case, in fact. If the NAO loses that case, then there's a very real, again, it's showing that business relationship is on the books to be determined. I notice my time's wrapping up here, so I apologize. We would just ask that if the board does want to investigate or have a conversation about the regulation of this entity. We haven't really had one in a while. I know we worked on previous legislation collaboratively with the board to make the process more efficient. We can look at online registration done in many other states to ease the workload burden. We're more than willing to do that. But the suggestion to move this to the optometry board creates serious concerns. And at the end of the day, the consumer will pay if you start regulating the industry in a way that compresses the market. Any questions?
No, actually, I thought that scope was in a different place, but now I see where the scope issue is. I think your point is well taken. It's anything which cuts down the competition. And one competitor to regulate the other is a serious issue in my mind.
And I need to clarify really quick, the optometry board did not have a full discussion about this. Much like this process, the issue was put in front of them. They modified the report to say that the board will be discussing it at a later date. They have not had a full discussion as the board about whether they want to move forward with this, that their report will reflect that the board is considering this option based on the enforcement process. I was there for that.
So can I ask a clarifying question? When there are consumer complaints about a dispensing optician, they come to the medical board? I don't remember ever seeing one.
We never have.
That's
It's
a pretty
probably
straightforward process.
the last time we actually took disciplinary action against one of those individuals was probably when it was under the Division of Licensing. I'd have to look at the report. You may have seen one.
I've never seen any, and I've been on the board a long time.
Let me just check real
It's
quick.
related to the, there was an unlicensed optician. I think you went after an optician practicing without being registered. But you couldn't do much about it because they were not
It's a
registered.
medicine, that's not just what it's
Yeah.
Right.
Sorry, you are correct. I apologize.
I guess my assumption on reading the background material was one of the reasons for this is that the skill and expertise to oversee the functioning of dispensing opticians doesn't reside among. We don't have any dispensing opticians on the board.
No, well, it's a registration process, as was pointed out. It's not a licensing process. It's like in most states, you register so you know where they exist, essentially, and that they are aware of California law. But it is not. It's not a licensing. So we've never asked to have an individual on the board as an industry because it's a registration, and I think there's a difference.
So another point of clarification: it's a business.
It's
not a skill set.
It's actually a business and a person and a.
You have to know something to do this job.
Yes.
And if you don't do the job well, is an individual injured?
Well, right
you
now.
just get new glasses.
Yeah, I stepped on my glasses and need an adjustment, and I'm feeling injury right now, but that's not their fault. But yeah, I mean, if
So
you
if
have
you
a
go to the
proper
market and you drop the
adjustment.
carton of milk on the floor and it spills, they clean up the milk and you go buy another carton of milk.
Yes.
Okay, so it's not like you've gotten food poisoning from the milk. You've not gotten an infection from milk. So I'm trying to understand what it is you guys do.
Actually, I need to
Let's,
be clear. Let's sparse this out in two ways. So you do get for eyeglasses, there is a sort of a coursework and an association that you're certified by. Contact lenses also has, and that is actually very important because you need to make sure those contact lenses fit properly.
Either
for
chances
the.
am I going to optician for that or slim?
No, you don't go to an optician, but I want to make sure you understand that this is opticians and contact lens dispensers. So that
these are both.
Mhm. So, but a contact lens dispenser is overseen by an optometrist or an ophthalmologist for that process.
Ophthalmologist is medical doctor.
Yes.
Kurtzmeyer had.
In the last 3 fiscal years, you've taken 9 actions against them in one way or another. So you've seen them. You might just not have noticed the difference between them. And it could have been against the spectacle lens or contact lens. It was probably more than likely against an individual in that regard.
There must have been some
must
That's
not have been
the
done right.
individual and not their
Yeah, it was probably, it was, yeah,
Optical
more than
dispensing.
likely it's the contact lens dispenser or the
Dishonesty.
spectacle lens. So 9 actions.
Okay.
Yeah,
Dr. Bishop?
I'm just trying to see how we can take this separately, and what I'm trying to do is let the staff work with this RDOs and see what's the best way to resolve. I can understand that it doesn't look like they fit really well into medical board, but the solution we're suggesting might be even worse. So that's why I just want to know what can we do working with them rather than just dump them off on somebody else. So it just didn't make sense to me.
And again, it will go through the legislative process with public testimony there as well.
I just had a comment that I agree we don't want to throw someone to the lions, but I wonder as we go forward, because I also think it should not be under the medical board. Is there a way, as this goes forward, that we could ensure that they have adequate protection, such as a certain component of the optometry board must consist of these individuals to protect their rights? I think that would be perhaps satisfy both sides of the equation, if possible.
You could put those members, a representative. They've done that with other boards.
Okay, thank you. Mr. Hepburn?
I was going to say, it's sort of unusual that you would dictate the composition of a different state body, that's all.
Yes.
I have one last comment. Has there been a real issue? Are there a real burden? Is there, obviously we've been, I think there was a quote of since 1936. Is it broken? Is it a broken system right now? 9 cases, 3 years. Why are we getting rid of them?
I think it's just confusing to the public for the most part. I think that's where a lot of
Right,
it
but
comes
we
from.
do like the polysysmography or whatever.
But those are
medical assistants, I don't know, all those other guys,
But
right?
those actually, polysom are supervised by physicians and surgeons. Your medical assistants are licensed by physician and surgeons, I think.
Supervised.
Yeah.
Just, Scott, if I may just put up a legal counsel, as I understand it, the RDO is essentially a bricks and mortar place. It can be. It's a physical location.
The RDO is bricks and mortar.
So it differs considerably from our personal licenses that we issue for the person, the physician.
But there are other licenses issued to persons that you guys issue.
Correct.
So the RDO is
I'm just trying to set the, so an RDO, and within the RDO, there's usually an SLD, spectacle lens dispenser, or a CLD, a contact lens dispenser that actually does the suspense.
Yeah.
So you've got essentially a bricks and mortar place that we register, and then you have registered personnel working therein. Is that correct?
And that are required to be there, that you register as well.
Correct.
So for the purposes of a person, you register a person as
Correct.
well.
Okay. Just trying to set the floor and get the common understanding of where we were.
Okay, thank you. I believe we have one more public comment. Carrie, thank you. Carrie. Staravon.
My name is Carrie Staravon. I'm the current chair of the Midwifery Advisory Council to the Medical Board. In the interest of time, I'm going to save some of my comments from my report to the board tomorrow. But I think it's important for the board to realize as we move forward with these midwifery recommendations to the legislature, if we do in fact move forward with them, that there are really 2 issues. As with any newly licensed profession, and licensed midwives have only been licensed in this state, I think the first licenses were handed out in 1995, so less than 20 years. There are remedial things that need to happen because they didn't get thought about originally. And one of those is the medication issue. We're trained to use certain drugs and devices, but we can't obtain them unless we have a physician supervisor. And so that needs to be fixed because in the interest of public safety, if a licensed midwife is attending a woman for birth in her home and can't obtain antihemorrhagics, it's a problem. And it's a problem for the consumer. And so this board regulates professions to protect consumers. The second thing is the student issue. That was not really thought out when the original legislation was written, and now we need some clarifying pieces. Originally, the legislation was written with a clause to maintain the apprenticeship model of midwifery, which is a direct entry model. It's a midwifery is probably the second oldest profession in the world, and it's always been an apprenticeship model of training. And it's really important to many of us, older midwives in the state, to maintain that. All of the midwives that sit on Midwifery Advisory Council are apprentice trained. And if we're all of a sudden going to say, well, that's not a viable model, okay, well, so then what am I? A chopped liver? You know, did I not learn what I was supposed to learn? And we have a mechanism in the law for testing those individuals that go through that kind of a model of training, and it's called the challenge mechanism, and it's still in place, and nobody's suggesting that we repeal it. What that challenge mechanism does is it requires anyone who doesn't go through an approved school to document and verify a certain set number of experiences, to sit a complete challenge mechanism exam, which for me was an entire day of written and an entire day of clinical, and then to sit the licensing exam. So there are safeguards to the public for working with that. Assistants, some midwives can't work with another midwife because there isn't another midwife in their area, and they need an assistant, and we need to define what that looks like. So these are remedial areas. The other area is the supervision issue. And this board was directed to define the appropriate level of supervision by August of 2003. Okay? So I think we're nearly 10 years going here, and we can't do it because there's no agreement in the state over what that ought to look like. And so we absolutely need legislative help figuring this out. And so I really, really encourage you to move forward with this, and I am totally available to provide whatever support staff needs to work through these issues. Thank you.
Thank you.
I'll be very quick here. Regarding the midwifery issue, CMA has been very involved in all the discussions with the Midwifery Advisory Council. As you, I don't want to say punt, as you refer this issue to the legislature, and with Dr. Levine's point about, giving some direction from the board, we would hope that at a minimum that as you punt this issue to the legislature, that we are looking at further defining what that supervision should be, not removing the supervision requirement altogether. And I think for the purpose of the insurers and trying to get them on board, we can't make them insure anybody, but our experience has been the more we can do to help them define the risk, the more likely they are to want to insure it. So being more vague is probably going to be less helpful than being more specific. Thank you.
Thank you.
Dr. Levine, I have comments on a whole different part of the report. Is that all right?
Oh,
okay.
You mean other parts of the sunset review?
Right.
Yeah, let me just finish this piece. You have a better memory than I do. We have a motion on the floor. Okay. Yes. So remind us what the motion is.
I don't know.
It is to accept the specialty advertising going forward as it is, accept the RDO program one going as it is, and the 3 midwifery issues going forth.
Okay, and we may need to vote on these separately, is my sense.
I think the motion was to take them all together.
Okay.
But I would change my mind if that would be okay for you.
Well, can I get a sense from the board? Do you want to vote continue and vote on these as a single motion or separate them?
For me, as long as the RDO is taken out, I have no problem, because I do want a solution for that problem and solution may not be sending him to optometry boards. That's what I'm looking at.
Then maybe we should take the three separate.
Well, then what we'd have to do is sort of have an amendment, and make it the motion, we have to amend it.
Make her the motion, I already accepted the chair's prerogative back to me.
Well, and the seconder did too.
So,
We are already on the same page.
so we will, someone will move
I
to,
will change the motion to take it one at a time. So removal of specialty.
so we have a motion.
Eliminate the approval of the specialty
Boards.
First one.
Leaving the grandfathered ones already.
Yes. All in
Second.
favor? Any opposed? Okay. Can I have a motion regarding the midwifery issues and proceeding?
So the proceed as requested on the.
Yes.
I'm sorry, which one was this one?
Midwifery.
To go forward as was recommended.
Can I make a comment before we do that?
Yes.
My concern here is, I think the trouble we've had, we're trying to put a square peg in a round hole. We have a group of individuals who I'm not going to argue one way or the other what purpose they serve. However, it's clear that they do not totally embrace the medical model. In fact, they eschew it in many ways, yet they want to benefit from the medical model in every way possible. So I think we're really having trouble with that, and I really want to be sure. I must say I agree with the CMA that we need to be very careful going forward. I mean, for someone to say at this time in medical progress that we want to have an apprentice level of entry is foreign to me. I don't understand that at all. We have, in medical school, we have apprentice way, but we also have academics first. So I just want to say, I just want to go forward. I'm very concerned about the whole thing. I can see why it won't work, because it won't work. They're not medical providers in the sense we think of them normally as medical providers. And that's okay with me, but I'm just explaining, I think that's the problem. And I don't want to all of a sudden craft something to make an exception for a group just so they can practice. I mean, that's up to the legislature to make a plan. So I want to make very clear going forward, I don't support, again, I've said this before, crafting some exception for a group of individuals who don't fully embrace the medical model in the first place.
I don't think that's the motion on the table.
No, I just want to see, as we're voting going forward, I don't want this to be sent as a tacit approval of that.
So can we be specific about the wording that we are moving? In other words, can you read back to us the language?
Well, on this particular one, we don't have, unlike the others, we have a recommendation that you change the law, you do certain things. This particular one, we just basically lay out that it appears the physician supervision requirement needs to be addressed through the legislative process. But you might want to entertain adding something in there that without eliminating the supervision, I don't know where.
Right,
I'm not sure where the board wants to go right
Yeah,
now.
because what I asked was basically there isn't anything that we can do without legislation, right? Because the physicians are not going to be able to get malpractice coverage, and so therefore it's a moot point, right? Because they're not going to be able to get physician supervision because they can't get malpractice. So then it has to go back to legislation.
But
right?
this actually may be something where the legislature feels that they can bring the parties together,
right?
Fashion some kind of a plausible solution that might address some of the issues on the table. That's all that the recommendation is.
Right.
That let the legislature come to the table and try and address the barriers to care. That's all we're talking about. We're not anything more.
Created by prior legislation.
Right.
Okay. Okay.
So that's the motion.
A second?
Second.
All in favor?
Aye.
Any opposed? Okay. And the third is the registered dispensing optician program, and the recommendation.
The motion I'm making is to retract the recommendation which is recommended to send it to optometry board, and actually to work with RDOs and see if there is an alternative solution or what works. We don't know. We all understand that we are not the right place probably for that, but we need to also find the right place for them too.
So let me ask you a question. Should the legislature be party to that decision?
Don't have any problem with that.
I don't know. I'm asking the question. So if you were to move this forward as it was requested, understanding that it may not be co-located in the same place or in the appropriate place, should that discussion be going on here, or should that discussion, and I don't know, should that discussion be going on?
I just wanted to see actually if there is an alternative where when our staff works with the RDOs and the people who wear, these facilities plus the opticians, if there is an alternative solution, I don't know. I'm just trying to look for something rather than taking the competition away in the marketplace might not be a great idea. Coming from this board as a recommendation, that's how I'm looking at it.
I suppose, to be honest, the inconsistency or the incongruity is that the vast majority of what this board deals with is professional issues, professional practice issues, and it sounds like the RDO program is really registration of a business, and enforcement is essentially is the business being carried out according to the way it's supposed to be, as opposed to is the care that's being delivered professionally appropriate. So, so it is a goldfish in a bear cage.
Does the Department of Consumer Affairs oversee any programs as an entity?
Not as a board. They have bureaus under them.
The possible
There you go.
solution
There you go.
might be consider transferring the RDO program to another appropriate agency, such as the Department of Consumer Affairs, without specifying, such as, and leave it at that.
Perfect. All right, so let's see where we go with that.
I'm
So
okay
you
with
want to
that.
make that motion?
Yes.
Okay, so,
Second?
I'll second it.
Okay.
That's 1 second. I have no need to second.
Great.
I'm happy to second. I don't want to talk.
I'll third it then.
I'll second it, it's fine. Okay, so you have a motion on the table.
Is there any public comment on the
Public
motion?
comment?
10 p.m.
Any public comment on the motion? 10 p.m.?
No, I am in favor.
We're talking about I was explaining this as the longest meeting in the night that we've gone.
And I'm perfectly okay with
He's
it.
perfectly okay.
We just need you to vote. Don't worry about
I said aye.
Okay, no public comment on the motion.
Comment from our representative.
No.
Okay, then we're ready to vote. All in favor? Aye. Any opposed? Okay, we have you have your marching orders, and do I sense that there's a sentiment to close the meeting?
Oh, why? We're having
Bring dinner in, we're fine.
Dr. Levine, if I can just ask one thing of the member, sorry. We would like, if there's any other sections that you have edits in, if you could provide those edits to us prior to October 30th, because we do need those if you find anything like Dr. Bishop found or any other technical minor edits that you need to be made, if we could receive those by October 30th, that way we can go ahead, or during this meeting.
Yeah, that's what
Yes, it is. We have to have it done by the 31st, so.
Okay, because this is our only opportunity to discuss sunset review, Julie had some comments about another section.
Thank you, Dr. Levine. Julie D'Angelo Felmuth. I'm with the Center for Public Interest Law at the University of San Diego School of Law. I have a few comments on your discussion of vertical enforcement, or VE, in Section 5, which starts on page 94, and I want to identify some omissions. For the benefit of the new members, I served as a medical board enforcement monitor from 2003 to 2005, and my team had an opportunity to audit all aspects of the medical board's enforcement and diversion programs. Our centerpiece recommendation, which was enacted in 2005, although not in the ideal manner that we had hoped, called on the medical board and the Health Quality Enforcement Section, or HQE, at the Attorney General's office to abandon their old handoff method of investigating and prosecuting
disciplinary matters, and instead shift to vertical enforcement, which is a more efficient method which calls for early interaction between the investigator and prosecutor and contemplates a team approach. Vertical enforcement was enacted in 2005 in a bill that was supported by the Medical Board and the Attorney General's office. Now, this new approach constituted a sea change, a culture change for the investigators and the prosecutors because they weren't accustomed to working together. Change is difficult. The investigators particularly chafed at a provision of the new law that required the investigation to be conducted under the direction of the prosecutor. The legislature clarified that provision a few years later. The law was clarified to provide that the investigation proceeds under the direction of the prosecutor, but the investigator continues to be supervised by a medical board supervising investigators. In our view, this should really not be a controversial issue. This is the way this is done at other law enforcement agencies that investigate and prosecute complex matters at the state, local, and federal levels. That was 2006. This is 2012. My team, which included a 30-year career public prosecutor who has used vertical enforcement every single day of his 30-year career, we never said that you would grow accustomed to this new system overnight. But we did not dream that 6 years later it would still be resisted in the way that this report does in Section 5. Under vertical enforcement, your case investigation cycle time has been cut by 20% since 2008. That's what this report says. On page 105, the report lists 7 other bullet points indicating major improvements in your enforcement program. Since you began to use VE in 2006, you have sent 47% more cases to the AG's office. You have sent 74% more probation violations to the AG's office. Working together, you and HQE have succeeded in getting 49% more interim orders and suspension restrictions pending the conclusion of the long disciplinary process. You have identified and referred 200% more cases for criminal action. You've succeeded in getting 35% more revocations and 26% more disciplinary outcomes. This is all on page 105. This is very impressive. And these accomplishments have been made despite the furloughs, despite the hiring freezes and the budget cuts and the 25% vacancy rate that you describe repeatedly. But Section 5 of this draft report distracts from these accomplishments by criticizing the AG's office for simply drawing different conclusions from the data in the 2010 Ben Frank report, a report that really did not and could not measure the impact of VE on the quality of decision-making being made about which cases to pursue and which cases to drop or settle. And the improvements in your investigative case cycle times that you now cite are not consistent with the findings in Mr. Frank's report of 2 years ago. So I'm really not sure how much you should be relying on that report. You're reporting very positive improvements. Instead of distracting from those, instead of criticizing HQE, which is supposed to be your partner, instead of refusing to credit VE for any of these accomplishments, I think you should be embracing VE in this report and seek its extension with improvements to better protect patients. And if you're going to criticize HQE in this document, you should also take a look in the mirror and discuss this board's actions, or lack thereof, to implement Senate Bill 797 Ridley-Thomas, which was passed in 2008. That bill required this board to do 3 things to enhance the VE model. 1, increase its computer capabilities with HQE. 2, establish and implement a plan to locate medical board investigators in the same offices, or at least cities, as HQE prosecutors. And 3, establish and implement a plan to assist in team building between the 2 sets of folks. Very little has been accomplished in any of those 3 areas, and that's not discussed in this report. In fact, this report does not even list SB 797 on page 28 under 2008 legislation impacting this board, and it should. It doesn't list Senate Bill 231, which was our big bill in 2005, on page 27. I'm sure these omissions were oversights in a 400-page report, but I would urge you to include them. This report also does not discuss the fact that the Medical Board and HQE continue to track case and report case cycle times differently in ways that make each other look better. That's not teamwork. That's a disconnect that's really not appropriate 6 years later. And it's now requiring board member time because Dr. Lowe is having to meet with the 2 sides to reconcile the data. In short, I think this is a good report. I do not quarrel with most of your very good recommendations in Section 11, but I think you should rethink the tone of Section 5, its reliance on a report that this board has not even looked at in 2 years, and whose findings are no longer true, and its critique of the AG's office when this board actually shares some of the responsibility for the continuing VE implementation problems. One last, and it'll take 5 seconds. This report contemplates a spring 2013 supplemental report about the costs of VE and other data that you're pulling together about VE. I believe that report should not only focus on the costs of VE. Somehow you've got to quantify the benefits. When you are pulling together, when you are securing 49% more interim suspensions and restrictions than you were 6 years ago, you are saving lives. This is the medical board. This is not the barber board or the landscape architect board. When you improve your enforcement program, you are saving lives, and somehow you have to quantify the benefits of VE instead of just counting its dollar costs. Thank you very much.
Thank you.
Madam Chair, I don't know if we can entertain the conversation tonight, but it seems to me that many of her points need to be dealt with, because particularly about the tremendous improvements. I know, my appointing authority, the Senate Rules Committee was extremely concerned about not only caseload, but how quickly they're turned around and the impact of that. And I think we need to do a better job explaining this has been successful. And then figuring out some of the, since this is a former board monitor, I would heed her advice closely that we need to look at what in the system is not working and why aren't we working together with the AG's office in a way that needs to be very positive. And so that we can move forward, get the improvements, and actually implement those things that were required by this the state legislation. So I'm hoping we can deal with that. I know we've had the last meeting stuff. I think we were behind whatever about talking about enforcement and things of that nature. But maybe we could deal with this time.
As was said, Dr. Lowe's has taken this on, and there's a fair amount of work that's going on, and he has been personally
My concern would be, though, a report going forward that really does not stress the improvements and the possibilities of this program in a way, because this is a public record. This is going to be a report to the legislature, and I would hope somehow we have some time or opportunity to make some of the suggested modifications on this aspect.
Okay, got that. Great. Any other comments before we adjourn?
Yeah, I just wanted to make a comment that when the Senate Rules Committee interviewed me for their attestation or to support the governor's nomination, they asked me, actually their statistics were all wrong, lots of them. Our enforcement does a significantly better job than what they thought we do. So we need to make sure that we are doing a great job. So I didn't have any trouble basically letting them know that your numbers are wrong. I mean, you got wrong numbers and you're accusing the medical board of something which is not true. So I just want to point out that.
Okay. All right. Can I have a motion to adjourn?
So
yeah, sure. We're not